Hello and welcome to your ultimate guide HESI Fundamentals exam. My goal today is give you everything that you need to understand the full concepts, master them, and walk you through the HESI Fundamentals exam with total confidence. In this video we will cover learning styles and patient teaching, nursing priority setting, wound care and dressings, universal fall precautions, Jackson-Pratt, drain management. With over 100 plus success stories, we have proven our videos will help you pass your exam on the first attempt. And remember, our website helps you to practice your HESI Fundamentals exam with our practice questions, timed mock exams, and study guides. You will find the link in the description below. So let's get started.
Question 1. A nurse plans education for a patient who reports learning best by watching demonstrations and trying skills with feedback. The nurse considers the matching approach. Learning style preferences guide the choice of teaching strategy, and using mixed methods often supports better retention while respecting the patient's preferred mode of intake. Your options are: A. Use only written pamphlets without demonstration. B. Lecture for 30 minutes without practice. C. Demonstrate skill, allow practice with feedback. D. Skip demonstration and rely on memorization. Which one is it? Pause the video if you need more time. The correct answer is C. Demonstrate skill, allow practice with feedback. C is correct because demonstration paired with return demonstration and feedback fits a kinesthetic and visual learner. The patient watches, practices, and receives immediate correction, which supports skill acquisition and confidence in performing the technique at home reliably. A is wrong, because using only written pamphlets without demonstration ignores the patient's preferred style. Reading alone may not support a learner who needs to see and try the skill, so written material works better as a supplement. B is wrong because lecturing for 30 minutes without practice does not match the preferred kinesthetic style. The patient needs hands-on practice with feedback rather than long verbal information, which can be hard to retain without active application here. D is wrong because skipping demonstration and relying on memorization fails the preferred learning style. The patient may not be able to perform the skill correctly without seeing and trying it, so the technique needs to be modeled. When health teaching fails, it's often not because the patient wasn't trying. It's because the method didn't match how that person actually learns. Understanding learning style preference is the key to making skills stick. The VARK model organizes learners into 4 categories: visual, auditory, reading and writing, and kinesthetic. A kinesthetic learner needs hands-on practice, not pamphlets or lectures. Those methods engage the wrong channel entirely. Kinesthetic learning works through motor memory. Watching activates mirror neurons, and physically performing the skill builds a procedural pathway that doesn't require conscious recall. Immediate corrective feedback closes the loop, catching errors while the motor memory is still forming. The correct strategy for a kinesthetic learner pairs demonstration, return demonstration, and real-time feedback, sometimes called the C1, do-one approach. This is fundamentally different from handing a patient a pamphlet, which feels thorough but matches the wrong channel. Be careful not to confuse learning style with health literacy or motivation. Health literacy is about comprehension of written material. Motivation is about willingness to engage. A return demonstration succeeds because the channel matches the learner, not because the patient becomes more motivated or more literate. Question 2. A patient admitted yesterday with a stroke now has a wet, gurgling cough during meals and a watery voice afterward. The patient also has chronic arthritis pain rated 3 of 10 and reports loneliness. The nurse must select the highest priority nursing diagnosis from these cues. Your options are: A. Chronic pain related to arthritis. B. Social isolation related to hospitalization. C. Deficient knowledge about stroke recovery. D. Risk for aspiration related to dysphagia. Take a second. Which answer would you pick? The correct answer is D. Risk for aspiration related to dysphagia. D is correct because risk for aspiration outranks the other options because a single aspiration event can produce pneumonia or asphyxia. Airway protection comes first, and the dysphagia cues here mark immediate severe danger to the patient. A is wrong because chronic pain at 3 of 10 is real but not life-threatening. Pain management matters for comfort, but it does not override an active threat to the airway from the patient's new swallowing problem. B is wrong because social isolation reflects an emotional need that fits lower on Maslow's hierarchy. The nurse must address physiologic threats first. Loneliness can be supported once the patient is medically safe to swallow. C is wrong because deficient knowledge about recovery is important for discharge but not urgent right now. Teaching has no benefit if the patient suffers an aspiration event today, so airway risk takes priority over learning needs. When a patient presents with multiple problems at once, nurses need a reliable system to decide what to tackle first. Priority setting frameworks prevent critical threats from being overlooked while attention is drawn to more visible complaints. The bedside framework combines Maslow's hierarchy with the airway, breathing, circulation sequence. Physiologic threats always outrank psychosocial concerns. And within physiology, airway and breathing sit at the very top because hypoxia causes brain injury within minutes. A stroke patient with a wet gurgling cough and a watery voice after meals is showing classic signs of pharyngeal pooling. Secretions that spill into the trachea instead of the esophagus can cause pneumonia within 48 hours or asphyxia within minutes. Exam writers frequently test whether students can distinguish a loud actual problem from acquired but deadly risk. Chronic mild pain is real, but risk of aspiration carries greater magnitude and immediacy of harm. So the risk diagnosis wins priority even though it produces no noise. Every time you see STEM language like highest priority, first action, or most important, ask yourself which problem produces the fastest and worst outcome if left alone. Look past the loudest cue to find the most lethal one hidden in the data. Question 3. A nurse is selecting a dressing for a clean granulating wound with minimal drainage. The wound bed is punk and the surrounding skin is intact. The nurse considers the dressing type that maintains a moist environment without causing trauma during changes. Many dressings exist for different wound stages. Your options are A. Hydrocolloid dressing for moist environment. B. Dry gauze packing changed every hour. C. Wet to dry dressing for granulation. D. Tight elastic wrap pressed against wound. Before I reveal it, which one do you think is right? The correct answer is A. Hydrocolloid dressing for moist environment. A is correct because hydrocolloid dressings maintain a moist wound environment and protect granulation tissue. They can stay in place several days, reducing dressing change trauma and supporting epithelialization in clean wounds with minimal drainage at this stage. B is wrong because dry gauze packing changed every hour disrupts new tissue and pulls away healing cells with each change. Frequent removal also dries the wound bed, which slows healing rather than supporting it during recovery. C is wrong because wet to dry dressings serve to debride wounds with dead tissue, not to support clean granulating wounds. Using them on healthy tissue removes new cells and is no longer recommended for granulating bases. D is wrong because A. Tight elastic wrap pressed against a clean granulating wound damages tissue. Pressure dressings have specific indications, such as vascular compression, but they are not used routinely on a clean granulating wound. Hydrocolloid dressings represent a major advance in wound care, built on the principle that a moist wound heals faster than a dry one. Understanding how they work means understanding the biology of epithelial migration. The dressing has two functional layers, the inner wafer made of gelatin, pectin, and carboxymethylcellulose, absorbs wound fluid and forms a soft gel that keeps the surface moist. The outer layer is impermeable to bacteria and water, protecting the wound while letting the patient shower normally. Research in the 1960s showed that occluded wounds heal nearly twice as fast as wounds left to dry. Dry scabs physically block new epithelial cells from migrating across the surface, stalling repair. Keeping the wound moist removes that barrier entirely. Each dressing has a specific wound profile. Hydrocolloid fits a clean granulating wound with a light drainage. Wet to dry debrides necrotic tissue but strips healthy granulation. Alginate handles heavy exudate. Foam suits moderate to heavy drainage, often over bony areas. The exam tests whether you can match the dressing to the wound stage. Pink granulating tissue, minimal drainage, and intact surrounding skin all point to a hydrocolloid. Choosing the wrong dressing, even a good one, can slow or reverse progress. Question 4. A nurse caring for a patient experiencing a panic attack notes rapid, shallow breathing, tingling fingers, and lightheadedness. The nurse considers the acid-base disturbance most likely developing during the episode. The pattern reflects the change in carbon dioxide that occurs with rapid hyperventilation during the acute anxiety event. Your options are A. Metabolic acidosis from anxiety, B. Respiratory acidosis from rapid breathing, C. Metabolic alkalosis from rapid breathing, D. Respiratory alkalosis from hyperventilation. What's your answer? Commit to one before I continue. The correct answer is D. Respiratory alkalosis from hyperventilation. D is correct because hyperventilation blows off carbon dioxide and creates respiratory alkalosis. Tingling and lightheadedness reflect the resulting alkalemia and reduced ionized calcium effect on nerve conduction, which produces the classic perioral and digital tingling. A is wrong because metabolic acidosis is unrelated to acute hyperventilation from anxiety. The mechanism described does not match a metabolic disturbance, so the option misidentifies the type of acid-base shift occurring during the episode. B is wrong because respiratory acidosis arises from carbon dioxide retention, not hyperventilation. Rapid breathing decreases carbon dioxide, producing alkalosis rather than acidosis, so the option contradicts the basic physiology in play. C is wrong because metabolic alkalosis develops from non-respiratory causes like vomiting or diuretic use. The mechanism here is purely respiratory, so the option misclassifies the body system responsible for the shift in pH. Respiratory alkalosis happens when rapid breathing removes too much carbon dioxide from the blood, driving pH above 7.45. Understanding the chemistry behind this helps you predict both the symptoms and the lab values. Carbon dioxide combines with water to form carbonic acid. When the lungs blow off excess carbon dioxide through hyperventilation, carbonic acid concentration falls, hydrogen ions decrease, and the bicarbonate to acid ratio shifts toward bicarbonate, pushing pH upward into the alkalotic range. The cascade begins with sympathetic outflow from anxiety, which drives breathing rate and depth upward. With every extra breath, more carbon dioxide is vented than the body produces, dropping the partial pressure of arterial carbon dioxide below 35 and tipping the system into alkalosis. Lower ionized calcium destabilizes nerve membranes, producing tingling around the mouth, paresthesia in the fingers and toes, and carpopital spasm. On the arterial blood gas, you will see a high pH paired with a low carbon dioxide and a normal bicarbonate, confirming the disturbance is respiratory and acute. Keep the four disturbances distinct. Respiratory alkalosis is the only one combining fast breathing, a low carbon dioxide, and a high pH simultaneously. Respiratory acidosis runs the opposite direction with retained carbon dioxide. Metabolic forms are driven by bicarbonate changes. not by ventilation rate. Question 5. A nurse is donning sterile gloves before performing a procedure. The nurse uses the open glove technique without a sterile gown. The glove package is open, and the nurse considers how to avoid contaminating the outside of either glove during the donning process at the small bedside table. Your options are A. Touch outer surface freely with bare hands. B. Pull glove on by gripping fingertips outside. C. Touch only inside cuff with bare hand. D. Slide glove over wet hands without drying. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is C. Touch only inside cuff with bare hand. C is correct because in open glove technique, the nurse touches only the inside cuff of the glove with the ungloved hand. Once one glove is on, the gloved hand touches only the outside of the second glove during donning. A is wrong because touching the outer glove surface with a bare hand contaminates the sterile exterior. The nurse must keep skin contact limited to the inside of the cuff during open glove donning at every step here. B is wrong because gripping the fingertips of the glove with the bare hand contaminates the part that will touch the patient. The nurse must instead pinch the inside cuff and pull the glove onto the dominant hand. D is wrong because wet hands snag the glove and can also wick contaminants through the material. Hands must be fully dry after hand hygiene before donning gloves to maintain sterility and avoid skin irritation later. Sterile open glove technique is how nurses don sterile gloves at the bedside without a sterile gown. It follows one absolute rule that governs every movement throughout the procedure. The defining rule is simple but unforgiving. Bare skin may only contact the inside of a glove, and a gloved hand may only contact the outside of the next glove. These two surfaces must never cross or contamination is immediate. The folded cuff is the mechanical key. The package presents each glove cuff folded outward, exposing only the inside surface. The dominant hand grips that inside cuff edge, slides in, and the gloved fingers then tuck under the outside of the second cuff to pull it on safely. Exam questions test whether you know what breaks sterility. Reaching for the glove fingertips with a bare hand contaminates the exterior instantly. Sliding gloves onto wet hands wicks contaminants through the material. Always keep the bare hand inside the cuff and the gloved hand outside. Open glove technique sits between two confusable alternatives. Closed glove technique is used in surgery with a sterile gown, hands still inside the sleeve. Clean glove use covers non-sterile tasks with no surface rules at all. Open glove is the precise, deliberate bedside middle ground. Question 6. A nurse is reviewing a list of diagnoses on a patient with newly diagnosed pneumonia. The instructor asks the student nurse to identify which one is a true nursing diagnosis rather than a medical diagnosis, since care planning depends on naming the patient response correctly. Your options are A. Impaired gas exchange related to alveolar changes. B. Community-acquired pneumonia, right lower lobe. C. Hypoxemia secondary to bacterial infection. D. Streptococcal pneumonia with consolidation. Which would you go with? Lock it in before the reveal. The correct answer is A. Impaired gas exchange related to alveolar changes. A is correct because impaired gas exchange names the patient response and identifies an etiology that nursing actions can address through positioning, oxygen, suctioning, and pulmonary hygiene. It fits the standard structure of a nursing diagnosis. B is wrong because community-acquired pneumonia is the disease itself, established by the medical team after imaging and cultures. Nurses do not diagnose pneumonia, they manage the human response that the disease creates. C is wrong because hypoxemia is a clinical sign defined by laboratory or oximetry data and falls under the medical diagnosis. While important, it is not a NANDA-style label describing the patient response to illness. D is wrong because streptococcal pneumonia with consolidation describes the organism and the radiographic finding, both medical territory. The nurse acts on the response, such as ineffective airway clearance, not the pathogen identification itself. A nursing diagnosis is not the same as a medical diagnosis. While physicians identify the underlying disease, nurses name how the patient is responding to that disease, and that distinction is at the heart of nursing practice. There are three related but distinct categories. A medical diagnosis names the disease itself. A collaborative problem is a complication the nurse monitors but cannot independently resolve. A nursing diagnosis names a human response that nursing actions can directly address. Nursing diagnoses are written using the PES format. The problem is a NANDA-approved label. The etiology introduced by related to names the cause the nurse can influence. The symptoms introduced by evidenced by are the cues that confirm the problem is real. Exam questions often hide medical labels among nursing options. NANDA labels like impaired gas exchange or acute pain describe human responses and are correct. Organism names like streptococcal pneumonia or imaging findings like right lower lobe consolidation describe pathology. Those are medical diagnoses and must be eliminated. Consider a patient admitted with community-acquired pneumonia. The medical team treats the pneumonia itself, but the nurse plans care around the patient's responses, impaired gas exchange, ineffective airway clearance, and activity intolerance. Each nursing diagnosis drives independent nursing actions the nurse can perform without a physician order. Question 7. A nurse cares for an older adult who wears full upper and lower dentures. The nurse considers safe denture care during the morning routine. The patient is alert and able to assist. Proper care prevents breakage, mouth injury and infection while keeping dentures in good condition. Your options are: A. Wash dentures over hard countertop quickly. B. Use boiling water to disinfect daily. C. Store dry overnight in a clean cup. D. Brush over towel-lined sink with water. Don't overthink it. Which one feels right? The correct answer is D. Brush over towel-lined sink with water. D is correct because brushing dentures over a towel-lined sink filled with water cushions any drop and prevents breakage. The nurse uses cool water in a soft brush, then stores dentures in solution overnight to keep them clean. A is wrong because hard countertops without padding risk shattering dentures if they slip from the nurse's hands. Dentures are expensive and difficult to replace quickly, so the nurse always lines the work surface with a soft towel. B is wrong because boiling water can warp denture material and ruin the fit. The nurse uses cool water for cleaning and a denture cleanser solution for soaking, never boiling temperatures that damage the acrylic structure. C is wrong because storing dentures dry overnight allows the material to warp and crack. The nurse stores dentures in clean water or a denture cleanser solution to maintain shape and reduce bacterial growth. Proper denture care protects both the prosthesis and the patient's oral health. Understanding why each rule exists makes it easier to apply them correctly at the bedside. Safe denture care is built on 4 anchors. Cool water prevents the acrylic resin from warping. A padded water-filled sink cushions any drop. A soft denture brush cleans without scratching surfaces where bacteria can hide. And overnight storage in solution keeps the prosthesis hydrated so it holds its shape. Dentures are made of acrylic resin, sometimes reinforced with metal. Resin warps under heat and cracks under impact. Scratched surfaces trap bacteria and cause infections like stomatitis or candidiasis. Metal components pit when exposed to bleach. The material itself explains every rule. Exam questions often present tempting but damaging alternatives. Boiling water seems like good disinfection, but destroys the prosthesis. Dry overnight storage causes shape change. A hard countertop without padding invites cracks. Knowing why each mistake fails reinforces the correct approach. A broken denture can take weeks to replace and costs the patient hundreds of dollars, time and nutrition they cannot afford to lose. 4 simple habits at the sink protect both the equipment and the oral cavity that depends on it every day. Question 8. A nurse is teaching a patient about prevention of pneumonia after a recent hospitalization. The patient is older with chronic respiratory disease. The nurse selects the most effective preventive measure that has the greatest impact on reducing future pneumonia risk and supporting overall respiratory health and well-being long-term. Your options are: A. Receive recommended pneumococcal and flu vaccines. B. Avoid all outdoor activity year-round. C. Take daily antibiotics indefinitely as prevention. D. Limit fluid intake to small amounts. Got a guess? Lock it in. The correct answer is A. Receive recommended pneumococcal and flu vaccines. A is correct because pneumococcal and influenza vaccinations reduce the risk of pneumonia in older adults and those with chronic respiratory disease. The vaccines protect against common causative organisms and are part of standard preventive guidance for the population. B is wrong because avoiding all outdoor activity is unnecessary and harmful to overall health. The patient benefits from regular activity, fresh air, and social connection, and complete isolation produces deconditioning rather than infection prevention long term. C is wrong because daily antibiotics indefinitely as prevention promote resistance and adverse effects. Antibiotics are reserved for active infections under specific circumstances, and chronic prophylactic use is rarely indicated for the general adult population. D is wrong because limiting fluid intake worsens hydration and thickens secretions, making pneumonia more likely. Adequate hydration thins mucus and supports clearance, which is the opposite of the suggested restriction here. Preventing pneumonia in vulnerable adults comes down to one cornerstone intervention: vaccination. 2 vaccines are at the center of this strategy: the pneumococcal vaccine and the influenza vaccine. The pneumococcal vaccine targets Streptococcus pneumonia, the leading bacterial cause of community-acquired pneumonia. The influenza vaccine reduces viral infections that pave the way for bacterial superinfection, because viral and bacterial causes often act together. The mechanism is immune memory. The vaccine presents bacterial surface antigens in a controlled way, prompting memory B cells to form. When the real organism arrives later, the immune system recognizes it within hours, not days, and clears it before it can establish infection in the lungs. Exam questions often include plausible-sounding distractors. Daily prophylactic antibiotics drive resistance without preventing pneumonia. Avoiding outdoor activity causes deconditioning. Vaccination is the only option that delivers durable risk reduction without harmful trade-offs. Whether the STEM mentions an older adult with COPD, an immunization schedule, or long-term pneumonia prevention, vaccination is the answer. Both the pneumococcal series and the annual flu vaccine should be confirmed and completed before discharge. Question 9. A nurse caring for a patient with cold extremities, nail polish on the fingers, and tremor wonders why the pulse oximeter waveform looks unreliable. The nurse considers the limitations of pulse oximetry that explain inaccurate readings in this clinical scenario before concluding that the patient is truly hypoxic right now. Your options are: A. Pulse oximeter accuracy is unaffected here. B. Reading is accurate even with cold limbs. C. Cold limbs and polish reduce signal quality. D. Polish improves reading by reflecting light. Which one is it? Pause the video if you need more time. The correct answer is C. Cold limbs and polish reduce signal quality. C is correct because cold extremities, dark nail polish, and motion all reduce signal quality on a pulse oximeter. The nurse warms the digit, removes polish if possible, or moves the probe to another site for an accurate reading. A is wrong because pulse oximeter accuracy is affected by perfusion, polish, motion, light interference, and other factors. Treating the device as foolproof leads to false reassurance or false alarm and can result in poor decisions. B is wrong because cold limbs reduce peripheral perfusion and cause inaccurate or low readings. The probe relies on pulsatile blood flow through the digit, so any condition that reduces flow weakens the signal noticeably. D is wrong because dark nail polish absorbs the light used by the oximeter and produces falsely low readings. Removing the polish, applying the probe sideways, or using the toe or earlobe site improves accuracy reliably. Pulse oximetry revolutionized bedside monitoring by giving clinicians a continuous, non-invasive window into oxygen saturation. But the device has real limits, and knowing when to question the number is just as important as reading it. The probe works by shining red and infrared light through a pulsating capillary bed and measuring how much each wavelength is absorbed. Oxygenated and deoxygenated hemoglobin absorb these wavelengths differently, and the device calculates saturation from that ratio with each heartbeat. 4 conditions commonly degrade pulse ox accuracy. Cold extremities vasoconstrict and reduce pulsatile flow. Dark nail polish absorbs the red wavelength and falsely lowers the reading. Motion or tremor confuses the algorithm, and poor perfusion weakens the signal entirely. When the reading seems inconsistent with the clinical picture, act on the source of artifact first. Warm the hand. Remove nail polish with an acetone wipe or move the probe to an earlobe or a clean finger. A corrected reading that rises quickly confirms the original value was artifact, not true desaturation. The key clinical skill is distinguishing signal artifact from true hypoxemia. Artifact is suggested when the number conflicts with the patient's appearance or shifts with probe position. True hypoxemia is supported by signs of distress and a pattern that fits the diagnosis. Never rely on the device number alone. Question 10. A nurse caring for a post-operative patient on the unit considers measures that prevent atelectasis. The patient is alert with stable vital signs and is 2 hours after abdominal surgery. The nurse selects independent actions that support lung expansion and prevent pulmonary complications in early recovery. Your options are bed rest, no ambulation, no cough. B. Restrict all fluid intake post-operatively. C. Prevent any analgesia for safety reasons. D. Incentive spirometry, deep breathing, ambulation. Take a second. Which answer would you pick? The correct answer is D. Incentive spirometry, deep breathing, ambulation. D is correct because incentive spirometry, deep breathing, coughing, and early ambulation expand the lungs and prevent atelectasis. Adequate analgesia supports the actions, since pain limits movement and breathing depth, and the team coordinates these measures every shift consistently. A is wrong because bed rest with no ambulation or cough invites atelectasis and pneumonia. The lungs collapse with shallow breathing and pooled secretions, which is exactly what early mobility and coughing maneuvers are designed to prevent here. B is wrong because restricting fluid intake worsens secretion thickness and slows clearance. The patient needs adequate hydration to keep mucus thin enough to mobilize, except in specific situations like fluid overload requiring restriction in the plane. C is wrong because preventing analgesia leaves the patient in pain and unable to participate in pulmonary hygiene. The nurse provides pain control so the patient can take deep breaths, cough, and ambulate without unnecessary suffering at all. After surgery, the lungs face a perfect storm of threats. Anesthesia suppresses the respiratory drive. Incisional pain triggers shallow breathing, and immobility allows small airways to collapse within hours, making active nursing intervention essential. General anesthesia reduces functional residual capacity, and pain near the chest or abdomen makes every deep breath hurt. Within hours, shallow breathing collapses alveoli, trapping secretions and setting the stage for infection. The bundle has 4 core components. Incentive spirometry reopens collapsed alveoli. Deep breathing and coughing mobilize secretions into larger airways. Early ambulation increases tidal volume and drives venous return. And analgesia is the enabler. Without adequate pain control, the patient simply cannot perform any of the other 3. Pain control is part of pulmonary care, not a competing priority. The correct sequence is to give a scheduled analgesic dose, wait 20 to 30 minutes for onset, then guide the patient through spirometry with a pillow splinting the incision, followed by ambulation. Once pneumonia develops, the patient needs antibiotics and possibly oxygen. Collaborative care. Prevention belongs to nursing, and it only works when every element of the bundle is delivered together, every time. Question 11. A nurse evaluates a post-operative patient 1 hour after administering an opioid for pain. The patient now reports pain 3 of 10. Breathing is even and unlabored at 16 per minute, and ambulates short distances in the room with steady gait. The nurse classifies the outcome. Your options are A. Outcome met as documented and continue plan. B. Outcome not met and revise plan now. C. Outcome partially met and add new diagnosis. D. Outcome no longer relevant and discontinue. Before I reveal it, which one do you think is right? The correct answer is A. Outcome met as documented and continue plan. A is correct because the patient achieved a measurable pain rating below 5, breathing remained safe, and mobility improved. All elements of the planned outcome are present, so the nurse documents the outcome met and continues current care. B is wrong because outcome not met would require findings that the goal failed, such as continued severe pain or worsening breathing. The data here clearly shows success, so revising the plan is unnecessary at this evaluation point. C is wrong because partially met would apply if some elements improved while others did not, such as pain easing while ambulation remained limited. Here, every component improved, so the partial label does not fit the data. D is wrong because outcome no longer relevant only applies when the underlying diagnosis no longer exists. Acute pain still exists at 3 of 10, so continuing reassessment of the same outcome remains appropriate going forward. Evaluation is the phase where the nurse deliberately compares what actually happened to what was planned. It is not a casual check. It is a structured judgment that determines whether care should continue, be revised, or end. After reassessing the patient, the nurse assigns one of 3 judgments: outcome met, outcome partially met, or outcome not met. Each judgment directly drives the next action: continuing the plan, revising it, or closing it out. Evaluation only works when the original goal was written to be measurable. A strong outcome names the patient, uses an action verb, sets a concrete threshold, like pain at 4 out of 10 or below, and specifies the time frame for reassessment. The mechanism works as a direct comparison. The nurse reassesses the patient after the intervention and holds that result against the original target. The match or mismatch between actual and planned determines the label that goes into the chart. The most tested trap is confusing outcome met with outcome no longer relevant. Outcome met means the goal was achieved while the diagnosis is still active. Outcome no longer relevant is reserved for when the underlying problem has disappeared entirely, like an infection that has fully cleared. Question 12. A nurse caring for a post-operative patient observes increased dressing saturation, drop in blood pressure, and rising pulse over the past hour. The patient appears pale. The nurse considers the most likely complication, and the priority action while preparing to escalate care for the developing situation at the bedside. Your options are A. Document and continue routine assessment. B. Encourage walking around the room briefly. C. Apply pressure, notify provider, monitor vitals. D. Stop intravenous fluids to reduce flow. What's your answer? Commit to one before I continue. The correct answer is C. Apply pressure, notify provider, monitor vitals. C is correct because increased saturation, hypotension, and tachycardia suggest post-operative bleeding. The nurse applies direct pressure, notifies the provider, monitors vital signs, prepares fluids and possible blood products, and watches for signs of progression toward shock. A is wrong because documenting and continuing routine assessment misses a developing emergency. The findings call for immediate intervention and escalation rather than passive observation, since hemorrhage worsens quickly and the patient can deteriorate during the wait. B is wrong because encouraging walking around the room is unsafe with active bleeding and dropping pressure. Mobility increases blood loss and the patient may collapse during ambulation, making the action contraindicated in the current situation. D is wrong because stopping intravenous fluids worsens hypovolemia from blood loss. The patient needs more volume, not less, and the nurse should anticipate orders for fluid resuscitation and possible transfusion rather than stopping the existing infusion. After surgery, unexpected blood loss can escalate rapidly into hypovolemic shock. Understanding the body's compensatory response helps nurses catch deterioration before it becomes irreversible. As blood volume falls, baroreceptors in the carotid, sinus, and aortic arch detect reduced stretch and trigger the sympathetic nervous system. This raises heart rate and constricts peripheral vessels, keeping blood pressure near normal while producing pale, cool skin. The cardiovascular system holds blood pressure near normal until about 15% of volume is gone. After that, pressure drops sharply and organs lose perfusion. The kidneys also release renin, retaining fluid and sodium. Each compensation leaves a clinical fingerprint nurses can detect. The correct priority sequence is to apply firm direct pressure over the dressing, alert the provider immediately, and maintain intravenous fluids to support perfusion while monitoring vital signs every 5 minutes. Not all shock is hemorrhagic. Septic shock presents with fever and warm flush skin early on, while cardiogenic shock involves chest pain or pulmonary congestion. The saturated dressing combined with early shock signs in a post-operative patient is the key clue that names hemorrhage. Question 13. A nurse is teaching a patient about rotating insulin injection sites. The nurse considers why rotation matters. Repeated injection in the same spot causes lipohypertrophy and unpredictable absorption. The patient asks about safe site rotation that supports steady glucose control during daily insulin therapy at home over time. Your options are A. Use only one site for steady absorption. B. Inject anywhere randomly each day. C. Avoid abdomen as a site. D. Rotate within an area for consistent absorption. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is D. Rotate within an area for consistent absorption. D is correct because rotation within a single anatomic area gives more consistent absorption than rotating between areas. The patient picks the abdomen or thigh or upper arm and moves around within that area, leaving an inch between injections. A is wrong because using only one site causes lipohypertrophy and erratic absorption over time. The tissue thickens and stops absorbing insulin reliably, which leads to unpredictable glucose control and possible severe swings during therapy. B is wrong because random injection anywhere each day produces inconsistent absorption between body areas. Different anatomic sites absorb insulin at different rates, and the variability complicates glucose management for the patient unnecessarily during therapy. C is wrong because avoiding the abdomen unnecessarily eliminates one of the most reliable absorption sites. The abdomen is a preferred site for many insulins because of consistent and predictable absorption rates compared to limbs. Insulin site rotation is more than just avoiding the same spot. It's a strategy built around predictable absorption. Understanding why and how to rotate helps explain glucose patterns that might otherwise seem impossible to control. Repeated puncture of the same site causes lipohypertrophy, a firm, thickened lump in the subcutaneous tissue. Insulin injected through that lump is absorbed unpredictably, causing erratic highs and lows. Studies link unrotated sites to worsening A1C and dangerous hypoglycemia, especially when a patient finally switches to healthy tissue and absorbs the same dose far faster than expected. Each body region absorbs insulin at its own characteristic rate. The abdomen is typically the fastest, while the thighs, upper arms, and upper buttocks are progressively slower. This is why rotating between unrelated areas on consecutive days can make the same dose act at very different speeds. The correct technique is within area rotation. Choose one region, place each new injection at least 1 inch from the last, and only move to a new area after the first has had several weeks to recover. This keeps the absorption rate consistent from dose to dose, making glucose control far more predictable. The key principle to remember: rotation prevents tissue damage, but staying within one area at a time is what keeps absorption consistent. Always inspect for lumps and never inject into thickened tissue until it has fully recovered. Question 14. A nurse considers ethical principles guiding patient care. One principle protects the right to make decisions about one's own body and care. The nurse identifies the principle by name. The framework helps nurses balance care with respect for the person as a self-determining individual. Your options are A. Autonomy, B. Beneficence, C. Justice, D. Non-maleficence. Which would you go with? Lock it in before the reveal. The correct answer is A. Autonomy. A is correct because autonomy is the principle that protects the patient's right to make informed decisions about their own care. Nurses respect autonomy by providing information, supporting choice, and not coercing the patient into specific treatments at any time. B is wrong because beneficence is the principle of doing good for the patient. The principle is important but distinct from autonomy, which centers on the patient's right to make decisions even when the choice differs from clinical recommendations. C is wrong because justice is the principle of fair distribution of resources and equal treatment. The principle does not specifically protect the patient's right to make decisions about their own care, which falls under autonomy as defined. D is wrong because non-maleficence is the principle of doing no harm. The principle is about avoiding injury rather than supporting decision-making, so it does not match the description of autonomy as the right to choose. Autonomy is the ethical principle that protects a competent patient's right to make informed decisions about their own body and care. The word itself means self-rule, from the Greek autos, self, and nomos, law. Honoring autonomy requires 3 things: information, a clear, honest explanation of diagnosis, treatment options, alternatives, and risks, voluntariness, a decision made free from coercion, and capacity, the cognitive ability to weigh the information and choose. When all 3 are present, the decision belongs to the patient. Medicine once operated on a paternalistic model. The clinician decided and the patient complied. After the Nuremberg Code in 1947 and the Belmont Report in 1979, the field shifted. The patient became a partner in care, not a passive recipient of expert decisions. Exam questions often offer lookalike principles as distractors. Beneficence is doing good. Non-maleficence is avoiding harm. Justice is fair allocation of resources. Only autonomy specifically protects the individual's right to self-determination. None of the others name that right. When a competent patient refuses treatment or chooses against medical advice, the nurse's role is to document, support, and arrange appropriate resources, not to override. Autonomy means the choice belongs to the patient, even when the team disagrees. Question 15. A nurse is applying a nasal cannula to a patient with mild hypoxia. The provider has ordered 2 liters per minute. The nurse considers the expected oxygen concentration at this flow rate. Knowing approximate concentrations helps the nurse anticipate effects and plan reassessment after the device is placed. Your options are A. Approximately 10% oxygen delivered. B. Approximately 50% oxygen delivered. C. Approximately 28% oxygen delivered. D. Approximately 90% oxygen delivered. Don't overthink it. Which one feels right? The correct answer is C. Approximately 28% oxygen delivered. C is correct because at 2 liters per minute, the nasal cannula delivers about 28% oxygen. The concentration rises roughly 4% per liter. With practical use, up to about 6 liters before drying becomes a concern. I was wrong because 10% oxygen is below room air, which is 21%. Nasal cannula adds oxygen to inspired air rather than reducing it. So the option misrepresents the function of the device entirely. B is wrong because 50% oxygen exceeds what a nasal cannula can deliver. Higher concentrations require partial rebreather, non-rebreather, venturi, or high-flow nasal cannula systems built for that level of delivery instead. D is wrong because 90% oxygen requires a non-rebreather mask with reservoir bag at high flow. A standard nasal cannula at 2 liters does not approach that concentration in any clinical scenario. A nasal cannula is the most common low-flow oxygen device used at the bedside. Understanding how flow rate translates to inspired oxygen concentration is a core nursing skill. The rule of thumb is simple. Room air starts at 21% oxygen, and each additional liter per minute adds roughly 4 percentage points. At 6 liters per minute, you reach about 44%. Beyond 6 liters, the flow dries nasal mucosa and concentration gains become unreliable. The mechanism is dilution. The prongs deliver supplemental oxygen into the nares, where it mixes with surrounding room air during each breath. The resulting inspired concentration depends on the flow rate set, plus the patient's own tidal volume and respiratory rate. The nasal cannula dominates low-flow oxygen therapy because it is comfortable, allows normal eating and conversation, and is simple to apply. Masks are only escalated when the cannula cannot achieve the target concentration, since they interfere with communication and nutrition. When you see nasal cannula on an exam, apply the 4% per liter rule. Any answer below 21% or above 44% is outside cannula range and should be eliminated immediately. Question 16. A nurse calling a provider about a patient with worsening shortness of breath plans the message using a structured communication tool. The nurse wants to give a clear summary that will move the provider to a decision quickly. The nurse selects the framework most consistent with the safe handoff approach. Your options are A. Situation, background assessment, recommendation framework. B. Long detailed history first, then situation. C. Random order of facts as they come. D. Diagnosis only with no other context. Got a guess? Lock it in. The correct answer is A. Situation, background assessment, recommendation framework. A is correct because situation background, assessment, and recommendation create a structured handoff that delivers the most important information upfront. The framework helps providers act quickly because the request and reasoning are clearly stated. B is wrong because leading with a long, detailed history before the situation buries the urgent point. Providers need the immediate concern first, with background and supporting data following so the call drives a decision. C is wrong because a random order of facts wastes the provider's time and obscures the clinical urgency. Structured communication exists to reduce this kind of confusion, especially during rapid changes in patient condition during care. D is wrong because sharing only the diagnosis without context, vital signs, or recommendation gives the provider too little to act on. The provider needs the situation, current findings, and a specific request from the nurse. SBAR is a structured clinical communication framework that organizes urgent messages so providers can act quickly. It was adapted from naval aviation in the early 2000s and later adopted by the Joint Commission after patient safety reports linked poor handoffs to preventable harm. Each letter has a concrete role. Situation leads with the immediate concern. Background frames it with relevant history. Assessment delivers the nurse's clinical impression. Recommendation closes with a specific request, giving the provider a clear decision point. Picture a nurse calling an on-call provider at 2 a.m. She opens with the situation, moves through background and assessment with objective findings, and ends with a recommendation naming exactly what she needs: a chest film, a bronchodilator, and consideration of escalated monitoring. SPAR is distinct from IPASS, which adds illness severity and receiver synthesis and is common in residency training, and from head-to-toe reporting, which works for routine shift handoff but is too slow for urgent calls. Unstructured narratives bury the critical point and delay the decision. When the STEM mentions a provider call, a change in condition, or a structured handoff, think SBAR. The correct answer always leads with the situation and closes with a specific actionable recommendation. Question 17. A nurse is feeding a patient who has had a stroke and recently been cleared for a soft diet. The nurse is reviewing positioning to prevent aspiration during meals. The patient sits in the chair beside the bed with the meal tray within easy reach during the lunch period. Your options are: A. Position flat on back during meal. B. Tilt head back while patient swallows. C. Recline at 30 degrees during eating. D. Sit upright at 90 degrees during meal. Which one is it? Pause the video if you need more time. The correct answer is D. Sit upright at 90 degrees during meal. D is correct because sitting fully upright at 90 degrees during and after meals reduces aspiration risk after stroke. Gravity helps direct food past the trachea, and the upright posture supports safe swallowing throughout the entire meal. A is wrong because lying flat allows food and gastric contents to enter the airway and is the worst position for aspiration risk. The patient cannot generate the swallow mechanics needed to keep the airway protected. B is wrong because tilting the head back during swallowing opens the airway to food rather than directing it to the esophagus. Chin tuck or neutral head position is generally preferred to protect the airway. C is wrong because reclining at 30 degrees is not adequate for active eating. The patient needs full upright posture for the swallow mechanics to work safely. Semi-recumbent angles increase the chance of aspiration. After a stroke, protecting the airway during meals is a critical nursing priority. Let's look at why positioning matters so much and what happens when the swallow goes wrong. The pharyngeal swallow is a tightly timed sequence. The airway must close, the esophageal sphincter must open, and the bolus must be propelled downward all within about 1 second. Stroke damages the cranial nerves and cortical centers that coordinate this, so the timing breaks down and food can silently fall into the larynx instead of the esophagus. Sitting fully upright at 90 degrees does three things at once. Gravity pulls the bolus downward toward the esophagus. The diaphragm can move freely to support the swallow, and a slight chin tuck narrows the airway entrance. Staying upright for 30 minutes after eating also prevents gastric reflux from bringing food back up before the lower esophageal sphincter has fully closed. Exam questions often test whether you can reject the wrong positions. Lying flat is the highest risk posture. Tilting the head back opens the airway directly to food. And reclining at 30 degrees is not adequate for active oral eating. Only full upright at 90 degrees meets the standard for stroke patients cleared for an oral diet. One final point worth memorizing. Oral feeding after stroke requires a full 90 degrees, while enteral tube feeding calls for 30 to 45 degrees. Both use gravity, but the angle differs. Knowing which scenario the question describes prevents a very common exam mistake. Question 18. A nurse is preparing to discuss a procedure with a school-aged child and the parents. The nurse considers developmentally appropriate communication. The child is alert and curious. Tailoring communication to the child's level supports cooperation and reduces fear, while keeping the parents engaged in the conversation. Your options are: A. Use complex medical terminology with the child. B. Speak only to parents, exclude child. C. Use simple words, allow questions, include parents. D. Tell child procedure will not hurt. Take a second. Which answer would you pick? The correct answer is C. Use simple words, allow questions, include parents. C is correct because simple language, opportunities for questions, and inclusion of parents support school-aged children. The child develops trust through honest, age-appropriate communication, and the parents reinforce understanding during and after the conversation as the procedure approaches. I is wrong because complex medical terminology overwhelms a school-aged child. The level of language must match the child's developmental stage, with simple, direct words and concrete examples to help the child grasp what will happen. B is wrong because speaking only to the parents and excluding the child is disrespectful and unhelpful. The child experiences the procedure firsthand, and exclusion from the conversation increases fear and reduces the chance of cooperation in the moment. D is wrong because telling the child that the procedure will not hurt sets up broken trust if there is any discomfort. Honest, age-appropriate descriptions, including expected sensations, help the child cope better than false reassurance during care. When caring for school-aged children, the way we communicate is just as important as the care itself. Children between 6 and 12 are concrete thinkers. They understand cause and effect, but cannot yet process abstract or technical language. Piaget called this the concrete operational stage. Children here can follow logical reasoning about real objects but struggle with abstract concepts. This is why clinicians translate medical events into tangible images: a small soft tube in the arm, a quick pinch, a special light that takes a picture inside the body. Picture a nurse sitting at the child's eye level, showing the equipment and naming what will happen in plain words. A parent stays close to anchor the child emotionally. The child is offered a small choice: which arm, restoring a sense of control. Every correct answer on this topic rests on 3 principles. Use simple, concrete language, invite and answer questions honestly, including whether something will hurt, and keep parents present. False reassurance breaks trust permanently and makes every future encounter harder. Keep in mind that each developmental stage calls for a different approach. The school-age strategy sits between preschool play and adolescent independence. Waxara sol fix or seed, concrete language, direct honesty, and parental presence working together. Question 19. A nurse is reviewing an arterial blood gas result for a patient. The pH is 7.32, the partial pressure of carbon dioxide is 56, and the bicarbonate is 24. The nurse considers the most likely acid-base disturbance from these three values. Your options are A. Metabolic alkalosis with full compensation. B. Respiratory alkalosis without compensation now. C. Metabolic acidosis with no respiratory shift. D. Respiratory acidosis without metabolic compensation. Before I reveal it, which one do you think is right? The correct answer is D. Respiratory acidosis without metabolic compensation. D is correct because the low pH and high carbon dioxide define respiratory acidosis. The bicarbonate sits within the normal range, indicating that no metabolic compensation has occurred yet, so the imbalance is uncompensated at this point. A is wrong because metabolic alkalosis would show a high pH and high bicarbonate. Neither pattern is present here, since the pH is acidic and the bicarbonate sits at the bottom of the normal reference range only. B is wrong because respiratory alkalosis would show a high pH and a low carbon dioxide. The pH and the carbon dioxide both move in the wrong directions for that diagnosis at this point in time. C is wrong because metabolic acidosis would show a low pH and low bicarbonate. The bicarbonate sits at 24 within the normal range, so the abnormality is respiratory rather than metabolic in origin here today. Respiratory acidosis occurs when the lungs fail to remove carbon dioxide fast enough, causing blood pH to fall below 7.35. Understanding the mechanism helps you read an arterial blood gas correctly and act quickly at the bedside. In uncompensated respiratory acidosis, the pH is low, the carbon dioxide is elevated as the primary driver, and the bicarbonate remains normal because the kidneys have not yet had time to respond. Interpret any blood gas in 3 steps. First, identify the pH side, states acid or alkaline. Next, find which value matches. CO2 for respiratory, bicarbonate for metabolic. Then check whether the other value has shifted to compensate. The clean clue for respiratory acidosis is the pair of low pH and high CO2, distinguishing it from metabolic acidosis. Metabolic alkalosis and respiratory alkalosis comes down to which value, CO2 or bicarbonate, moves in the direction that explains the pH shift. When bicarbonate stays normal, compensation has not begun and the disturbance is uncompensated. Spot the cause. Opioids. It's up there. Neuromuscular weakness or pneumonia, and intervene before severe acidosis below 7.2 causes arrhythmia. Question 20. A nurse just administered intravenous morphine to a patient with severe post-operative pain. The nurse considers the appropriate timing for reassessment of pain after this route of administration. Reassessment is part of the nursing process and must occur within a window suited to the medication's onset of action. Your options are A. Reassess within 15 minutes after intravenous dose. B. Reassess after 60 minutes routinely. C. Reassess at end of shift only. D. Reassess after 4 full hours pass. What's your answer? Commit to one before I continue. The correct answer is A. Reassess within 15 minutes after intravenous dose. A is correct because intravenous opioids reach peak effect within 15 to 30 minutes, so reassessment around 15 minutes is appropriate. The nurse evaluates pain reduction, sedation level, respiratory rate, and any side effects after each dose. B is wrong because 60 minutes is too long for intravenous opioid reassessment, since the peak effect has already passed. Earlier reassessment captures the medication's action and allows timely response to either inadequate relief or adverse effects. C is wrong because waiting until end of shift skips multiple reassessment windows and ignores the cycle of dosing and response. The nurse must reassess after every dose and again at intervals matching the medication's pharmacokinetics. D is wrong because 4 hours after an intravenous dose is well past the peak and does not capture the medication's effect. Oral medications need reassessment around an hour, but intravenous routes work much faster. After giving an intravenous opioid, the nurse must reassess the patient at the right moment, time to when the drug actually peaks. This principle is pharmacokinetic, not arbitrary. Intravenous medications bypass absorption entirely, reaching peak plasma concentration within minutes. For most IV opioids like morphine, hydromorphone, and fentanyl, the analgesic peak arrives between 15 and 30 minutes after administration. A timely reassessment at 15 minutes serves 3 purposes. It confirms whether the medication produced adequate relief, catches early signs of oversedation or respiratory depression, and guides the nurse's next clinical decision. The reassessment clock changes with the route. Intravenous peaks at 15 minutes. Oral opioids peak around 60 minutes due to absorption. Subcutaneous and intramuscular fall in between. And transdermal patches take 12 to 24 hours to reach steady state. The nurse who matches the reassessment window to the route can document analgesia at exactly the right time, avoiding both undertreated pain and missed opioid toxicity. Question 21. A nurse is preparing an intramuscular injection of a medication that can stain or irritate tissue. The nurse plans to use the Z-track technique and considers the proper steps. Z-track seals the medication in the muscle and prevents tracking back through the subcutaneous tissue at the site. Your options are: A. Pull skin tight and inject quickly. B. Inject into subcutaneous fat layer. C. Pull skin laterally, inject, release after. D. Massage the site after injection. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is C. Pull skin laterally, inject, release after. C is correct because Z-track technique pulls the skin laterally before injection, holds during injection, and releases after needle withdrawal. The skin returns to position and creates a zigzag path that traps the medication inside the muscle. A is wrong because pulling the skin tight and injecting quickly does not create the Z-track displacement. The skin must move laterally, not just be tightened, and the release happens after the needle has been withdrawn from the tissue. B is wrong because injecting into subcutaneous fat misses the muscle and is not Z-track technique. The medication intended for intramuscular use can cause tissue damage and slower absorption when given subcutaneously by mistake. D is wrong because massaging the site after injection is contraindicated with Z-track because it pushes medication out of the muscle. The seal created by the technique is meant to keep the medication within the muscle tissue. Z-track is a specialized intramuscular injection method designed to seal medication inside the muscle and prevent it from leaking back into surrounding tissue. Understanding the mechanism helps explain why each step of the technique matters. When the skin is pulled about an inch laterally and held, the tissue layers shift relative to each other. The needle enters the muscle through a tract that no longer lines up with the surface entry point. Once the needle is withdrawn and the skin is released, the layers slide back, creating a zigzag seal that traps the medication inside the muscle. The 3 critical steps are: pull the skin laterally about 1 inch, inject slowly and wait 10 seconds before withdrawing the needle, then release the skin without massaging. Massaging the site would force medication back along the tracks that were just sealed. Z-track was first developed for medications like iron dextran and hydroxyzine that stain or irritate tissue if they leak. Today it is recommended for most intramuscular injections. The most common exam errors are pulling the skin taut rather than laterally, and massaging afterward, both of which defeat the zigzag seal. Z-track works because misaligned tissue planes physically trap the medication in the muscle. Get the sequence right: lateral displacement, slow injection, needle withdrawal, skin release, no massage, and the seal holds. Question 22. A nurse discovers a colleague made a medication error. The colleague administered a wrong dose to the patient and the patient is currently stable. The nurse considers the appropriate action that protects the patient and supports system learning under just culture principles, guiding the unit's response to medication errors. Your options are A. Hide the error to protect colleague. B. Report the error per institutional policy. C. Punish the colleague harshly in private. D. Ignore since no apparent harm yet. Which would you go with? Lock it in before the reveal. The correct answer is B. Report the error per institutional policy. B is correct because reporting the error per institutional policy supports patient safety and system improvement. The nurse documents, monitors the patient, and contributes to root cause analysis under just culture, which separates human error from reckless behavior. A is wrong because hiding the error blocks system learning and leaves the patient at risk. Just culture exists specifically, so honest reporting can lead to better processes, and concealment undermines the entire safety framework around the system. C is wrong because harsh punishment discourages reporting and does not address contributing system factors. Just culture distinguishes human error from reckless behavior and uses the event for learning rather than blame against the nurse involved. D is wrong because ignoring the error because no apparent harm has occurred misses the point of near-miss reporting. Today's stable patient might have a delayed reaction, and the system gains nothing without disclosure and analysis afterward. Just culture is a workplace philosophy that matches each type of error with the right response. Not punishment across the board, but structured accountability. It emerged from aviation safety in the late 90s and entered healthcare in the early 2000s, driven by evidence that punitive cultures drove error reporting underground. Just culture rests on three categories. Human error is an unintentional slip. The response is system improvement and coaching. At-risk behavior is drifting from policy without seeing the danger. The response is coaching and policy review. Reckless behavior is conscious disregard of obvious risk, and only here does disciplinary action apply. Just culture sits between two extremes. Blame culture punishes every error, suppressing reporting and hiding system failures. No blame culture excuses everything, including reckless behavior, removing accountability entirely. Just culture holds individuals accountable for choices, while holding the institution accountable for its systems. Regardless of who made the error or where the harm occurred, the right action is always to follow institutional policy, monitor the patient, complete an incident report, and support a system review. Hiding errors to protect a colleague or ignoring near misses each undermines the system and puts the next patient at risk. Open reporting is what allows institutions to find and fix the gaps that let errors happen. Just culture makes that reporting safe, and that safety is ultimately what protects patients. Question 23. A nurse is planning sleep-promoting interventions for a hospitalized patient who has trouble sleeping due to noise and frequent nighttime checks. The nurse considers the most effective non-pharmacologic intervention to support better sleep. The patient is otherwise stable and not on continuous monitoring during the overnight shift. Your options are A. Bright lights in the room overnight. B. Loud roommate activity is unavoidable. C. Cluster nursing care to allow rest periods. D. Frequent unannounced checks throughout night. Don't overthink it. Which one feels right? The correct answer is C. Cluster nursing care to allow rest periods. C is correct because clustering nursing care into fewer interruptions allows longer stretches of uninterrupted sleep. The nurse coordinates assessments, medications, and personal care so the patient experiences consolidated rest periods through the night. A is wrong because bright lights overnight disrupt circadian rhythm and prevent restorative sleep. Dim lighting and limited use of overhead lights during nighttime nursing care are part of standard sleep hygiene measures on the unit. B is wrong because loud roommate activity may be common, but can often be reduced with coordinated quiet times. Treating it as unavoidable misses the nursing role in advocating for the patient's environment and rest. D is wrong because frequent unannounced checks fragment sleep and prevent any deep stages from completing. The nurse should consolidate care and communicate timing whenever possible so the patient can anticipate and recover between visits. When patients are hospitalized, sleep is routinely disrupted by noise, light, and frequent room entries. Clustering nursing care is the practice of consolidating assessments, medications, and repositioning into fewer, longer visits so patients can experience extended uninterrupted rest. A complete sleep cycle lasts about 90 minutes and includes light sleep, deep sleep, and REM sleep. Deep sleep, the most restorative phase, occurs more in the first half of the night. A single interruption during deep sleep resets the entire cycle, stealing far more rest than just the minutes lost. Poor hospital sleep has serious consequences. It slows healing, worsens pain perception, raises delirium risk especially in older adults, and prolongs length of stay. These harms make sleep promotion a genuine clinical priority, not just a comfort measure. The clustering strategy bundles medications, vital signs, and repositioning into a single planned visit. The nurse enters quietly with a small task light, performs all care at once, and then leaves the patient undisturbed for as long as possible, ideally several hours at a stretch. Pharmacologic sleep aids like benzodiazepines increase delirium risk and are not first line in hospitals. The safest and most effective approach is clustering care, dimming lights, and reducing noise, protecting the sleep cycle without adding medication risk. Question 24. A nurse applies sequential compression devices to a post-operative patient at risk for venous thromboembolism. The nurse considers the proper use. The devices help prevent clots by mimicking calf muscle pumping. The nurse selects the action that fits standard practice when applying and managing the sequential compression device today. Your options are: A. Apply over both legs, ensure no twisting. B. Wrap directly over open wounds. C. Use only on one leg routinely. D. Leave on permanently with no breaks. Got a guess? Lock it in. The correct answer is A. Apply over both legs, ensure no twisting. A is correct because sequential compression devices are applied to both legs unless contraindicated, with sleeves smooth and untwisted. The nurse checks skin under the sleeves, removes them only as ordered, and inspects pulses and skin during periodic checks. B is wrong because wrapping the device directly over open wounds traumatizes the wound and contaminates the sleeves. Open lesions, ischemia, and recent vascular surgery are typical contraindications to applying compression sleeves to that limb. C is wrong because using on only one leg leaves the other limb without protection. Both legs are at risk for clot formation, and bilateral application is the standard practice unless a specific contraindication exists for one side. D is wrong because leaving the device on permanently without breaks risks skin breakdown and pressure injury. The nurse removes sleeves periodically per institutional policy to inspect skin and confirm continued appropriate function during the stay. Sequential compression devices provide mechanical thromboprophylaxis by actively mimicking the body's own venous pump. Understanding how and why they work helps clarify when and how to apply them correctly. The device inflates the distal chamber first, then the middle, then the proximal, generating a peristaltic wave that pushes venous blood toward the heart. The cuffs then deflate together, allowing the veins to refill before the cycle repeats roughly every minute. Normally, walking contracts the calf muscles and squeezes blood back toward the heart. Immobility eliminates this pump, slowing venous return and letting blood pool. Pooled blood is far more likely to clot, making post-operative and bed rest patients especially vulnerable. Prevention combines two prongs: mechanical prophylaxis with sequential compression devices and pharmacologic prophylaxis with low molecular weight heparin. They are used together or separately depending on the patient's bleeding risk and clinical factors. Correct application means placing the device on both legs with sleeves lying smooth and twist-free, and checking the skin underneath at every shift. Never apply over open wounds or recent vascular surgery sites, and remove the device during ambulation. Question 25. A nurse is setting up a sterile field for a urinary catheter insertion at the bedside. The nurse considers the standard rules for sterile field maintenance during the procedure. The most important rule helps the nurse keep the field free of contamination during the catheterization itself. Your options are: A. Reach across the field freely as needed. B. Allow lower portions to drape on floor. C. Place items 2 inches from edge. D. Keep field within sight at all times. Which one is it? Pause the video if you need more time. The correct answer is D. Keep field within sight at all times. D is correct because an unattended, sterile field is considered contaminated, so the nurse keeps the field within sight until the procedure is complete. Turning the back or leaving the room invalidates sterility and forces the nurse to restart. A is wrong because reaching across a sterile field contaminates it because dust and skin cells from the arm shed onto the area below. The nurse approaches from the side and reaches around rather than over the field. B is wrong because lower portions of the drape that hang below waist level are considered non-sterile. The nurse cannot use any item that touched a low-hanging portion and must keep the field above the waist. C is wrong because items must remain at least 1 inch from the edge of the field, since the very edge is considered non-sterile. 2 inches is even safer, but placement specifically must avoid the edge in either case. Once a sterile field is set up, one rule overrides all others. The field must stay within the nurse's line of sight at all times. This isn't just a procedural detail, it's the foundation the entire concept rests on. The reason is simple. There is no way to look at a sterile field and know it is still sterile. If the nurse steps away, a passerby, a curtain, or even a pet could contaminate it, and without continuous observation, the only safe assumption is that it has been compromised. The other sterile field rules support the same logic. Items must stay at least 1 inch from the drape edge. Everything below waist level is contaminated. Reaching across the field is forbidden, and supplies are added using the side approach only. Picture the draped overbed table. The sterile zone sits in the center, bounded by a 1 inch non-sterile margin at every edge. The nurse stands beside it, never leaves, adding supplies from the side, keeping everything above waist level. If the nurse steps away for any reason, the field must be discarded and rebuilt from scratch. Keeping visual control of the field is what validates every other rule. Lose sight of it, and sterility cannot be assumed. Question 26. A nurse encourages early ambulation after surgery for a stable patient. The nurse considers the benefits of moving as soon as safely possible. Early ambulation reduces complications across multiple body systems and supports faster recovery, which is why it forms a routine part of the post-operative care plan today. Your options are: A. Reduces wound healing through extra motion. B. Reduces venous thromboembolism and pneumonia risk. C. Increases postoperative pain dramatically. D. Prevents normal bowel function from returning. Take a second. Which answer would you pick? The correct answer is B. Reduces venous thromboembolism and pneumonia risk. B is correct because early ambulation reduces venous thromboembolism, atelectasis, pneumonia, illus, and deconditioning. The action improves circulation, ventilation, and bowel motility, helping the patient recover faster and avoid the most common postoperative complications during the stay. A is wrong because early ambulation supports rather than reduces wound healing through improved perfusion. The option misstates the effect, since gentle activity brings oxygen and nutrients to the healing tissue and promotes recovery overall. C is wrong because pain may briefly increase with movement but is managed through analgesia and pacing. The benefit of early mobility outweighs the discomfort, and the nurse coordinates pain control to allow movement without unnecessary suffering. D is wrong because early ambulation supports the return of bowel function rather than preventing it. Walking stimulates peristalsis and helps prevent ileus, which is one of the standard reasons to mobilize the patient after surgery. Early postoperative ambulation means deliberately getting a stable surgical patient walking within hours of recovery from anesthesia. It sits at the center of modern enhanced recovery protocols because its benefits touch virtually every body system. Prolonged bed rest accelerates muscle wasting, slows bowel return, depresses lung expansion, and produces deep vein thrombosis. Walking prevents all four: venous thromboembolism, atelectasis and pneumonia, postoperative illus, and muscle deconditioning. Walking activates the calf muscle pump, which propels venous blood back to the heart and prevents stasis-induced clotting. Deeper breaths during ambulation expand alveoli and mobilize secretions, while increased abdominal motion stimulates peristalsis and restores bowel function. Exam writers exploit three common misconceptions: that ambulation impairs wound healing, dramatically worsens pain, or delays bowel return. Each is the opposite of the truth. Walking improves wound perfusion, pain is manageable with planned analgesia, and bowel function returns faster with mobility. Passive range of motion exercises maintain joint mobility but cannot replicate the calf pump effect or lung expansion of upright walking. For the stable surgical patient, the longer ambulation is delayed, the more complications accumulate. Question 27. A nurse caring for a patient with a recent traumatic head injury considers positioning to support venous drainage from the brain and limit increases in intracranial pressure. The patient is on continuous monitoring and is otherwise hemodynamically stable for the entire current shift right now. Your options are: A. Strict flat supine with neck flexed. B. Head turned sharply to the side. C. Head of bed at 30 degrees neutral. D. Trendelenburg position with feet elevated. Before I reveal it, which one do you think is right? The correct answer is C. Head of bed at 30 degrees neutral. C is correct because A. Head of bed elevation around 30 degrees with the neck in neutral alignment helps venous drainage from the brain. The position reduces intracranial pressure without compromising cerebral perfusion in a stable patient. A is wrong because strict flat supine with the neck flexed obstructs venous drainage and can raise intracranial pressure. Flexion or extension of the neck both compromise jugular outflow and worsen pressure inside the skull. B is wrong because sharp head turning compresses jugular veins, restricts venous drainage, and raises intracranial pressure. Neutral head and neck alignment is preferred so that drainage from the cranium is not impeded by the neck position. D is wrong because Trendelenburg with feet elevated raises intracranial pressure by increasing venous return to the head. The position is harmful in head injury and should not be used unless reversing severe hypovolemic shock briefly. when intracranial pressure rises. Something as simple as how a patient is positioned can make a significant difference. The key principle is that venous drainage out of the skull is gravity dependent and easily obstructed by mechanical compression. The cranium is a closed box. Brain tissue, blood, and cerebrospinal fluid share a fixed space. When bleeding or swelling increases any one component, pressure rises sharply, above 20 millimeters of mercury. Cerebral perfusion fails and ischemic injury begins. The internal jugular veins are the primary drainage pathway from the cranium. Elevating the head of bed to 30 degrees uses gravity to assist that drainage. Keeping the neck in neutral alignment, head forward, cervical spine straight, keeps the jugular veins open and uncompressed. Several common positions worsen intracranial pressure. Neck flexion and sharp head turning mechanically compress one or both jugular veins, slowing drainage. Trendelenburg pushes venous blood toward the brain. Hip flexion raises intra-abdominal pressure, which elevates central venous pressure and indirectly raises pressure inside the skull. Positioning is one of the most overlooked and directly nurse-controlled interventions for raised intracranial pressure. 30 degrees head of bed with the neck in neutral alignment keeps venous drainage unobstructed and cerebral perfusion protected. Question 28. A nurse is preparing a patient for an enema. The nurse considers which position best supports administration and patient comfort by allowing easy passage of the tubing and gravity-assisted flow into the colon. The patient is alert, cooperative, and able to lie on either side throughout. Your options are A. Supine with knees together. B. Prone with arms above the head. C. Half Fowler at 90 degrees. D. Left lateral with right knee flexed. What's your answer? Commit to one before I continue. The correct answer is D. Left lateral with right knee flexed. D is correct because the left lateral or modified Sims position with the right knee flexed follows the natural curve of the sigmoid colon. The arrangement eases tubing insertion and lets gravity assist solution flow into the rectum. A is wrong because supine with knees together does not align with the sigmoid curve and makes insertion uncomfortable. The position also reduces gravity assistance and increases the risk of rectal trauma during the procedure. B is wrong because prone with arms overhead is uncomfortable and impractical for enema administration. The nurse cannot easily access the rectum or monitor the patient's comfort and reaction during the procedure in this posture. C is wrong because half Fowler at 90 degrees works against gravity for fluid retention and is not the standard for enema administration. The patient may also have difficulty holding the solution upright for the necessary minutes. When administering an enema, patient positioning is not arbitrary. It's rooted directly in the anatomy of the colon and the physics of gravity. Understanding why the left lateral position works helps you apply it correctly every time. The sigmoid colon, the final segment before the rectum, curves naturally to the left side of the body. When the patient lies on the left side, the rectum sits below the sigmoid. So enema solution flows upward and to the left along that curve with minimal resistance. 3 factors make this position effective. It follows the sigmoid curve. Gravity assists solution flow from the rectum upward into the descending colon. And the flexed right knee opens the perineum to reduce sphincter tension and ease tube insertion. Common wrong answers include supine, prone, right lateral, and half Fowler. Supine pinches off the sigmoid curve. Prone makes rectal access impractical. Right lateral works against the colon's natural direction. And half Fowler forces solution to flow against gravity, making retention difficult. The left lateral position with the right knee flexed earns its standard status because it uniquely pairs the sigmoid colon's anatomy with gravitational assistance. No other position achieves both, which is exactly why exam writers return to it repeatedly. Question 29. A confused older adult with chronic mild incontinence is attempting to climb out of bed despite an unsteady gait, was given an opioid 1 hour ago, and has reddened skin over the sacrum that blanches with pressure. The nurse must select the highest priority nursing diagnosis. Your options are A. Impaired skin integrity related to moisture. B. Falls risk from confusion and sedation. C. Functional urinary incontinence chronic pattern. D. Disturbed thought processes related to age. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is B. Falls risk from confusion and sedation. B is correct because an imminent severe risk outranks slower developing actual problems. Climbing out of bed while sedated and unsteady creates a high chance of fracture in the next minutes. So prevention takes priority over comfort issues. A is wrong because skin redness that blanches is stage 1 risk for breakdown, not yet impaired skin integrity. Even if the diagnosis applied, a fall in the next minute would cause more immediate and severe harm. C is wrong because chronic incontinence is a long-standing baseline issue, not a sudden new threat. The diagnosis is real but stable. The patient will not be hurt in the next moment by ongoing urinary patterns. D is wrong because disturbed thought processes describe a contributing factor more than the chief priority itself. The nurse must act on what the confusion will cause, namely a fall, rather than the cognitive change in isolation. In nursing priority setting, we're taught that actual problems usually outrank risk diagnoses. But when a risk is both severe and imminent, that rule reverses, and understanding why is the key to safe clinical judgment. Priority is determined by which problem produces the worst outcome in the shortest time. A patient actively climbing out of bed while sedated can fracture a hip in the next minute, far faster than incontinence causes harm or redness progresses to skin breakdown. The mechanism involves compounding vulnerabilities. Older adults often have osteoporosis, slower reflexes, and may be anticoagulated. Add a recent opioid dose and an unsteady gait, and the same fall produces a far worse fracture or head injury than it would in a younger, unmedicated patient. Comparing the 4 diagnoses on a timeline makes the priority clear. Falls risk is the only one that can cause catastrophic harm within the next minute. The others are real and deserve care plans, but none can match that speed and severity of potential injury. When an imminent risk can cause irreversible harm faster than any actual problem on the list, it takes the top priority. Train yourself to rank by speed and severity, not just by whether a diagnosis is labeled actual or risk. Question 30. A nurse is preparing to enter the room of a patient on contact and droplet precautions for a respiratory virus. The nurse gathers gown, mask, eye protection, and gloves. The supervisor asks the nurse to demonstrate the correct donning sequence before entering the patient's isolation room together. Your options are A. Gown, mask, eye protection, then gloves. B. Gloves first, then mask, gown, glasses. C. Eye protection, then gloves, mask, gown. D. Mask, gloves, eye protection, gown last. Which would you go with? Lock it in before the reveal. The correct answer is A. Gown, mask, eye protection, then gloves. A is correct because the standard donning sequence is gown, mask, eye protection, and finally gloves. This order ensures that gloves cover gown cuffs and that respiratory protection is in place before entering the patient room. B is wrong because putting gloves on first would mean the rest of the equipment cannot be donned cleanly. Gloves go on last so they can cover the gown wrist cuff and remain intact during patient care. C is wrong because eye protection before gloves disrupts the standard sequence and risks contamination. The full body coverage from the gown should be in place first, then face protection, then gloves over the gown. D is wrong because putting gloves on before the gown means the gloves cannot be tucked under the gown cuff. This sequence leaves a gap at the wrist that can expose the nurse to body fluids during care. When preparing to enter an isolation room, the order in which you put on personal protective equipment is not arbitrary. It follows a precise sequence designed to create a seamless barrier from neck to fingertip. The CDC standardized sequence is gown first, then mask or respirator, then eye protection, and finally gloves. Each step builds on the last. Gloves pull over the gown cuffs to seal the wrist, and eye protection rests against the already secured mask without disturbing its seal. The geometry of coverage explains the logic. The gown anchors at the wrist. The mask forms the foundation the eye protection rests against, and the gloves seal over the cuff, creating one unbroken barrier with no skin exposed. Common exam distractors scramble the order in specific ways. Gloves first leaves the wrist exposed, applying eye protection before the mask can dislodge it. Each wrong sequence creates a coverage gap. Understanding why the correct order works helps you rule out every distractor confidently. Question 31. A nurse witnesses a patient develop sudden hives, lip swelling, and difficulty breathing minutes after the first dose of an antibiotic. The nurse recognizes anaphylaxis. The nurse considers the priority emergency action while a colleague calls for help and prepares additional equipment for support of the patient's deteriorating condition. Your options are: A. Document the reaction in the chart. B. Encourage patient to drink water. C. Apply cool compress to face only. D. Stop infusion and prepare epinephrine. Don't overthink it. Which one feels right? The correct answer is D. Stop infusion and prepare epinephrine. D is correct because stopping the infusion removes ongoing exposure, and epinephrine is the first-line treatment for anaphylaxis. The nurse maintains airway, applies oxygen, and prepares additional medications and equipment as the team responds to the emergency. A is wrong because documenting the reaction matters but never replaces immediate action. The nurse must intervene to protect airway and circulation, and charting follows once the patient has been stabilized through emergency medications and support. B is wrong because encouraging fluids cannot reverse a systemic allergic reaction. The patient has airway swelling and circulatory compromise. Oral hydration is unsafe and irrelevant during the acute event that is unfolding right now. C is wrong because a cool compress to the face does not address airway compromise or hypotension. Topical comfort measures have no role in treating the systemic allergic reaction, which requires immediate medication administration. Anaphylaxis is a rapidly developing, life-threatening systemic allergic reaction mediated by immunoglobulin E. Understanding why epinephrine works requires understanding exactly what goes wrong at the cellular level. Mast cells and basophils release histamine within minutes of antigen exposure, triggering 3 simultaneous crises: airway compromise, circulatory collapse, and skin manifestations. All 3 must be recognized together to diagnose anaphylaxis. Epinephrine is the perfect counter to every physiologic problem. Alpha stimulation reverses vascular leak and hypotension. Beta-1 stimulation restores cardiac output. Beta-2 stimulation reopens the airways by relaxing bronchial smooth muscle. 3 conditions can mimic anaphylaxis. A localized allergic reaction stays at the exposure site. Vasovagal syncope produces hypotension without hives or wheezing. Asthma exacerbation produces wheezing without skin changes. Anaphylaxis is the only one that combines skin, respiratory, and circulatory features simultaneously. At the bedside, the only failure mode that matters is delay. Stop the inciting infusion, recognize the combination of symptoms, and administer intramuscular epinephrine immediately. Every other intervention follows, but nothing replaces epinephrine first. Question 32. A nurse provides discharge teaching about a new medication. The nurse considers how to confirm the patient understands the instructions. Teach back is the gold standard. The technique invites the patient to repeat back the information in their own words rather than simply nodding agreement during the conversation. Your options are: A. Ask patient to explain in own words. B. Ask if the patient understands you. C. Have patient sign that teaching occurred. D. Read the instructions out loud one time. Got a guess? Lock it in. The correct answer is A. Ask patient to explain in own words. A is correct because asking the patient to explain in their own words confirms understanding through teach back. The nurse identifies misunderstandings, corrects them, and reinforces the teaching, which improves retention and adherence to the plan after discharge. B is wrong because asking if the patient understands often produces a polite yes regardless of true comprehension. The closed question does not test understanding, and the nurse should use teach back instead to check learning more accurately. C is wrong because having the patient sign that teaching occurred documents the activity but does not confirm understanding. The signature is a record, not an assessment of comprehension, and the nurse must use teach back to check learning. D is wrong because reading the instructions out loud once delivers information but does not confirm understanding. The nurse must check whether the patient absorbed and can apply the content, which requires the active teach back process during teaching. Teach back is a patient education technique in which the learner explains newly taught information in their own words. It is considered the gold standard for verifying understanding at the end of a teaching session. Closed questions like "Do you understand?" produce yes answers far more often than they produce true comprehension. Patients nod along out of politeness, embarrassment, or fatigue, not because they actually understood the teaching. Teach back replaces the closed question with an open invitation to explain. The nurse teaches, the patient explains in their own words, and any gaps are corrected immediately. The cycle repeats until the patient can describe the plan accurately. It is a coaching loop, not a single test. When the patient's explanation is incomplete, the nurse fills the gap and asks again. This loop continues until the patient can accurately describe the full care plan, including correct steps, sequencing, and no missing information. 3 common approaches are often confused with teach back. A nod or verbal yes is mere acknowledgement. A signed teaching form only documents that teaching occurred. Printed handouts support learning but cannot replace verification. Only teach back closes the loop and confirms true comprehension. Question 33. A confused older adult patient is climbing over the partial side rail of the bed and reaching for the window. The nurse considers what to do next, knowing that side rails can sometimes increase fall injury rather than prevent harm when the patient is determined to get out. Your options are: A. Raise all 4 side rails up. B. Lower bed, sit, address patient need. C. Apply a vest restraint over chest. D. Chart that bed is in low position. Which one is it? Pause the video if you need more time. The correct answer is B. Lower bed, sit, address patient need. B is correct because lowering the bed, providing a one-to-one presence, and addressing the underlying needs such as toileting or pain reduces both the urge to climb and injury severity if a fall occurs. A is wrong because raising all 4 side rails functions as a restraint and increases injury height when the patient climbs over. Many serious falls occur when the patient tumbles over rails to reach the floor. C is wrong because a vest restraint should not be applied without exhausting less restrictive alternatives and obtaining an order. Restraints have caused asphyxia and entrapment, especially in confused patients who continue trying to move. D is wrong because documenting the bed setting alone does not address the active climbing behavior. The nurse must intervene first by being present and meeting the underlying need, then chart the action and patient response. Falls are the leading cause of preventable injury in hospitalized older adults, and confused patients carry the highest risk. Understanding why patients climb out of bed and how to respond is the key to keeping them safe. The urge to leave bed is almost never random. Confused patients are responding to a real need: toileting, hydration, pain, or anxiety. Side rails and restraints block the action, but never address the underlying trigger, so the patient simply tries harder. The correct response has 3 components: lower the bed to floor level to reduce fall height, provide one-to-one presence to keep the patient calm, and directly address the underlying needs such as toileting or pain. A floor mat beside the bed further softens any accidental landing. Mechanically, a lower bed converts a dangerous fall into a much safer one. The shorter the drop, the less force on impact. Paired with a bedside fall mat, this simple adjustment dramatically reduces injury severity without restricting the patient at all. Raising all 4 side rails is legally and clinically classified as a restraint, and when a confused patient climbs over them, the fall height is greater. Vest restraints carry serious risks including asphyxia and entrapment, and require a physician order. Simply documenting a low bed without acting on the patient's need prevents nothing. Question 34. A nurse reviewing morning labs for a patient with chronic kidney disease finds a serum potassium of 6.8. The patient is sitting up and reports feeling fine. The nurse must decide what step matters most before completing the rest of the morning routine. Your options are: A. Document the value and continue rounds. B. Hold breakfast tray until potassium drops. C. Notify provider and place on monitor. D. Recheck the lab value in 8 hours. Take a second. Which answer would you pick? The correct answer is C. Notify provider and place on monitor. C is correct because A. Critical potassium of 6.8 raises serious risk of cardiac dysrhythmia. Notifying the provider and placing the patient on a monitor allows fast treatment and early detection of arrhythmia before collapse. A is wrong because charting alone does not address the immediate cardiac risk linked to severe hyperkalemia. The nurse must take action because critical values demand provider notification, not simple documentation in the record. B is wrong because holding the tray does not influence the existing hyperkalemia or its cardiac danger. Diet adjustments are part of long-term management, not the urgent priority for a value already this far out of range. D is wrong because waiting 8 hours to recheck while doing nothing leaves a dangerous level untreated. Hyperkalemia at 6.8 can produce peaked T waves, conduction blocks, and ventricular fibrillation rather quickly. When a serum potassium rises above 6.5, it becomes a critical value demanding immediate action. This threshold matters not because of how the patient feels, but because of what is happening electrically inside the heart. Potassium controls how easily heart cells fire. As extracellular potassium climbs, the resting membrane potential creeps toward the firing threshold. The EKG tells the story. Peaked T waves appear first, then the QRS widens, then a sine wave pattern emerges that can collapse into ventricular fibrillation or asystole. Recognizing these waveform changes is critical. The EKG is the real-time window into how hyperkalemia is destabilizing cardiac conduction, and continuous monitoring lets the nurse catch deterioration before the patient loses a pulse. The correct response has 4 pillars. Notify the provider immediately, place the patient on continuous cardiac monitoring, and prepare treatments. Calcium gluconate stabilizes the cardiac membrane. Insulin with dextrose shifts potassium back into cells, buying time while definitive removal therapies are arranged. A potassium of 6.8 in a patient who feels fine is still an emergency. The lab value is the early warning the patient's symptoms cannot provide. Notify, monitor, and prepare every time. Question 35. A nurse caring for a patient scheduled for orthopedic surgery participates in pre-op safety steps. The unit follows a process to prevent wrong site surgery. The nurse considers the standard practice that helps confirm the correct procedure and operative site before operating room transport. Your options are A. Verbal confirmation only on the day before. B. Allow OR team to mark only. C. Rely on chart note for site identification. D. Surgeon marks the site with patient awake. Before I reveal it, which one do you think is right? The correct answer is D. Surgeon marks the site with patient awake. D is correct because the surgeon marks the operative site with the patient awake and able to confirm. The mark stays visible after prep, and a timeout in the operating room verifies patient, procedure, and site before the incision. A is wrong because verbal confirmation only on the day before does not meet the safety standard. The mark on the patient is part of the process, along with the chart, the patient confirmation, and the timeout together. B is wrong because allowing the operating room team to mark the site without the surgeon misses the responsible person. The surgeon performs the marking with the patient awake to verify the correct site before any sedation. C is wrong because relying on the chart note for site identification has caused wrong site surgery in the past. The mark on the body is required because charts can contain errors that go uncaught without a physical confirmation. Wrong site surgery is one of the most preventable disasters in medicine. The Joint Commission responded by creating the Universal Protocol in 2004, which standardizes how surgical teams verify the correct patient, procedure, and site before every incision. The protocol has 3 required steps: preoperative verification using the chart and consent, surgical site marking performed by the operating surgeon while the patient is awake and can confirm, and a final timeout at the operating table with the entire team before any incision is made. The surgeon marks the incision site with an indelible marker while the patient is still awake and able to confirm the correct side. This mark must survive surgical preparation and remain visible through draping, so the team can still see it at the time of incision. The timeout is the last layer of redundancy. Every team member participates and verbally confirms the patient's identity, the planned procedure, the correct site and marked site, and any special equipment needed before the first incision. Exam questions test whether you recognize these violations, relying on verbal confirmation alone, allowing someone other than the surgeon to mark the site, using only the chart note for site identification, or failing to ensure the mark survives surgical prep. Each one bypasses a critical safeguard and violates the Universal Protocol. Question 36. A nurse caring for a patient on digoxin notes a heart rate of 52 with nausea and visual changes like yellow-green halos. The nurse considers the priority concern. Digoxin has a narrow therapeutic window, and toxicity can develop quickly if levels rise or hypokalemia develops. Your options are A. Hold the next dose and notify provider. B. Give the next dose at higher amount. C. Document and continue routine care quietly. D. Encourage extra dietary potassium loss. What's your answer? Commit to one before I continue. The correct answer is A. Hold the next dose and notify provider. A is correct because bradycardia, nausea, and visual changes signal possible digoxin toxicity. The nurse holds the next dose, checks the apical pulse and digoxin level, evaluates potassium, and notifies the provider for further direction and orders. B is wrong because giving a higher dose worsens toxicity and could cause severe arrhythmia. The action contradicts safe practice. since the cues already indicate too much medication relative to the patient's tolerance and metabolism today. C is wrong because continuing routine care quietly misses a developing emergency. The findings require immediate action, including holding the dose and contacting the provider, rather than passive monitoring while toxicity progresses unchecked at the bedside. D is wrong because encouraging extra dietary potassium loss worsens the risk of toxicity. Hypokalemia potentiates digoxin toxicity, so the nurse maintains potassium in the normal range rather than promoting loss of the electrolyte. Digoxin is a powerful cardiac drug with a narrow therapeutic window, meaning the line between a helpful dose and a dangerous one is razor thin. Understanding why toxicity happens and how to recognize it is essential for safe patient care. Digoxin works by inhibiting the sodium-potassium ATPase pump in cardiac muscle cells. This raises intracellular calcium and boosts contractility. But when extracellular potassium is already low, more digoxin binds to the pump, pushing the drug into toxic territory. The classic triad of digoxin toxicity includes bradycardia, gastrointestinal symptoms like nausea and anorexia, and visual disturbances, most characteristically yellow-green halos around lights. When all three appear together in a patient on digoxin, toxicity must be assumed immediately. Toxicity is commonly triggered by hypokalemia from diuretics, renal impairment that slows drug clearance, or drug interactions that raise digoxin levels. These factors can tip a stable patient into toxicity without a dose change. When toxicity is suspected, the nurse holds the next dose, checks the apical pulse for a full minute, draws a stat digoxin level in potassium, and notifies the provider. In severe cases, digoxin immune fab may be ordered as an antidote. Question 37. A nurse caring for an older adult on a medical unit reviews assessment cues that suggest dehydration. The patient has had decreased oral intake for several days. The nurse selects the cluster of findings most consistent with fluid volume deficit during the morning assessment after taking initial vital signs. Your options are A. Bounding pulse and elevated blood pressure. B. Crackles in lungs and bilateral pattern edema. C. Dry mucous membranes and decreased skin turgor. D. Distended jugular veins and weight gain. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is C. Dry mucous membranes and decreased skin turgor. C is correct because dry mucous membranes and decreased skin turgor are classic dehydration findings. The combination reflects intracellular water loss and supports a nursing diagnosis of fluid volume deficit, especially in the older adult during this day. A is wrong because a bounding pulse and elevated blood pressure better describe fluid volume excess. Dehydration typically presents with weak rapid pulse and lower blood pressure as circulating volume drops below the level needed for stable perfusion. B is wrong because crackles in the lungs and pitting edema reflect fluid volume excess, often from heart failure. The cues are the opposite of dehydration and would not appear in a patient with reduced fluid intake here. D is wrong because distended jugular veins and weight gain reflect fluid overload, not deficit. Both findings indicate the body is retaining too much volume and would not appear in a patient losing or restricting fluids. Fluid volume deficit occurs when water and electrolyte losses exceed intake. Understanding the underlying mechanism explains why the classic assessment findings appear together as a cluster. Reduced intravascular volume produces a faster, weaker pulse and falling blood pressure. Reduced interstitial volume causes poor skin turgor. Dry mucous membranes reflect lost surface water, and reduced renal perfusion concentrates the urine while cutting output. The full assessment cluster ties directly to those mechanisms. Dry membranes and skin tenting reflect interstitial loss. A weak rapid pulse with orthostatic hypotension reflects intravascular loss. Concentrated urine and acute weight loss complete the picture. 1 liter of fluid loss equals roughly 1 kilogram. Exam writers exploit confusion between deficit and excess. Deficit findings: dry membranes, skin tainting, weak rapid pulse, and concentrated urine are the opposite of excess findings like bounding pulse, pitting edema, crackles, jugular distension, and weight gain. Keep the dry, weak, low pattern paired with deficit. Older adults are especially vulnerable because thirst declines with age, and barriers like confusion, dysphagia, or fear of incontinence reduce intake further. When you see the dry, weak, low cluster, think fluid volume deficit first. Question 38. A nurse counsels a patient who smokes and was just diagnosed with chronic respiratory disease. The patient expresses interest in quitting. The nurse considers the most evidence-based approach to support cessation. The nurse plans a discussion that pairs counseling with available pharmacologic options for nicotine dependence. Your options are: A. Tell patient to stop smoking alone. B. Offer counseling plus pharmacologic support. C. Avoid the topic of smoking with patient. D. Recommend only herbal remedies for quitting. Which would you go with? Lock it in before the reveal. The correct answer is B. Offer counseling plus pharmacologic support. B is correct because counseling combined with nicotine replacement or other pharmacologic options doubles or triples cessation success. The nurse uses the 5 A's of ask, advise, assess, assist, and arrange to support each step of quitting. A is wrong because telling the patient to quit alone with no support has lower success rates. Most patients need both behavioral and pharmacologic help to quit successfully, and abandoning them to do it alone is unlikely to work. C is wrong because avoiding the topic misses an important teachable moment when motivation is high. The diagnosis itself often opens the door to honest discussion, and the nurse should engage rather than retreat from the conversation. D is wrong because recommending only herbal remedies provides limited evidence-based support for cessation. The nurse should mention proven options like nicotine replacement, varenicline, and bupropion as part of a complete and effective plan. When a patient is ready to quit smoking, the most effective strategy pairs behavioral counseling with pharmacologic support. Together, they roughly double or triple quit rates compared to either approach alone. Nicotine dependence has 2 dimensions. The behavioral side ties smoke into triggers like stress, coffee, and routine breaks. The physiologic side involves nicotinic receptor adaptation, producing craving, irritability, and poor concentration during withdrawal. 3 leading pharmacologic options soften withdrawal so patients can build new habits. Nicotine replacement delivers steady low-level nicotine without the sharp peaks of cigarette smoke. Varenicline occupies nicotinic receptors to blunt reward, while bupropion reduces craving through dopamine and norepinephrine pathways. Counseling is structured around the 5 A's: ask, advise, assess, assist, and arrange. This framework guides the nurse to identify triggers, build coping skills, review medication options, and schedule follow-up, keeping the conversation open over time. Abrupt cessation alone has the lowest success rates, and harm reduction is not equivalent to quitting. The combined behavioral and pharmacologic approach remains the standard for adults who are ready to stop. Question 39. A nurse caring for a patient with carbon monoxide exposure notes a pulse oximeter reading of 96%. The patient remains symptomatic with headache and confusion. The nurse considers why the oximeter may be misleading, since the device has known limitations with certain hemoglobin states. Your options are: A. Pulse ox cannot distinguish carboxyhemoglobin from oxyhemoglobin. B. Pulse ox is more accurate during exposure. C. Pulse ox signals true hypoxia clearly. D. Pulse ox values triple in poisoning Don't overthink it. Which one feels right? The correct answer is A. Pulse ox cannot distinguish carboxyhemoglobin from oxyhemoglobin. A is correct because standard pulse oximeters cannot distinguish carboxyhemoglobin from oxyhemoglobin and read falsely high. Oximetry from arterial blood is needed to identify carbon monoxide poisoning, since the patient may be hypoxic despite a reassuring oximeter value. B is wrong because the device is less accurate, not more, during carbon monoxide exposure. The reading does not reflect tissue oxygenation because the bound carbon monoxide blocks the binding sites without changing the device's measurement signal. C is wrong because the pulse oximeter does not signal true hypoxia in carbon monoxide poisoning, since the displayed value remains high while tissue oxygen delivery is impaired. The clinical picture matters more than the number here. D is wrong because values do not triple in poisoning. They typically read normal or near normal. The deceptive normalcy of the reading is precisely what makes the device unreliable in the specific clinical scenario in care. Carbon monoxide poisoning is a silent threat. The gas is colorless and odorless, and the standard monitor used to detect hypoxia will completely miss it. Understanding why requires looking at both the biology and the physics of how we measure oxygen. Carbon monoxide binds to hemoglobin at the same heme site as oxygen, but with roughly 200 times the affinity. The resulting carboxyhemoglobin cannot carry oxygen to tissues, producing hypoxia even when blood oxygen tension appears normal. Pulse oximeters shine 2 wavelengths of light through tissue and calculate saturation based on absorption. Carboxyhemoglobin absorbs red light almost identically to oxyhemoglobin, so the device counts it as oxygenated, displaying 95% or higher while the patient is actually hypoxic. Clinically, suspect carbon monoxide when symptoms like headache, nausea, and confusion follow a furnace or smoke exposure, especially with a deceptively normal pulse oximeter reading. Arterial blood gas with carboximetry is the only bedside test that directly measures carboxyhemoglobin saturation. The pulse oximeter is an essential tool, but it cannot distinguish carboxyhemoglobin from oxyhemoglobin. When exposure history and symptoms point to carbon monoxide, the normal reading on the screen is part of the danger, not reassurance. Question 40. A nurse is teaching a patient to use a metered dose inhaler with a spacer. The nurse considers the proper technique. The spacer holds the medication so the patient can inhale slowly without timing the puff perfectly. Correct use improves drug delivery to the lower airway. Your options are A. Inhale fast and hold for 1 second. B. Exhale into the spacer before puff. C. Slow deep inhale, hold 10 seconds. D. Take 5 rapid puffs in a row. Got a guess? Lock it in. The correct answer is C. Slow deep inhale, hold 10 seconds. C is correct because after triggering 1 puff into the spacer, the patient inhales slowly and deeply through the mouthpiece and holds the breath for about 10 seconds. The technique allows the medication to settle in the lower airway. A is wrong because inhaling fast prevents medication from reaching the lower airways and shortens the breath hold. A slow inhale gives time for particles to travel deeper, and a longer breath hold allows them to settle properly. B is wrong because exhaling into the spacer pushes the medication out of the chamber. The patient should exhale before placing the lips on the spacer mouthpiece, then trigger the puff and inhale slowly through the mouthpiece. D is wrong because taking 5 rapid puffs in a row delivers more medication than ordered and does not allow the lung to absorb each dose. Each puff is taken separately with proper technique and timing between attempts. A metered dose inhaler with a spacer removes the hardest part of inhaler use, the need to perfectly time your breath with the puff. The spacer holds the medication cloud suspended so you can inhale at a slow, controlled pace. The pressurized canister releases one measured puff into the spacer chamber. Inside that chamber, the aerosol cloud disperses. Larger particles fall out against the chamber walls, and the smaller respirable particles remain suspended, ready to travel deep into the airway. The correct sequence starts with a full exhale away from the mouthpiece, followed by one puff into the chamber. Then the patient inhales slowly and deeply over 3 to 5 seconds, and holds the breath for about 10 seconds so particles settle onto the airway lining. It is critical not to confuse devices. Dry powder inhalers require a fast, forceful inhale, the opposite of the MDI spacer technique. Nebulizers deliver a continuous mist over several minutes. Each device demands its own technique, and mixing them up means the medication never reaches the lungs. When you see metered dose inhaler with spacer on an exam, think slow, steady inhale and a 10-second breath hold. That combination is what separates effective aerosol delivery from medication lost in the throat. Question 41. A nurse assesses a wound on a patient's heel. The skin is intact but shows non-blanchable redness over the bony area, and the patient reports tenderness. The nurse considers the correct stage of this pressure-related skin change. Staging guides documentation and the next steps in the care plan. Your options are A. Stage 2 with partial thickness loss, B. Stage 1 with intact skin and erythema, C. Stage 3 with full thickness loss, D. Stage 4 with bone involvement visible. Which one is it? Pause the video if you need more time. The correct answer is B. Stage 1 with intact skin and erythema. B is correct because stage 1 pressure injury features intact skin with non-blanchable erythema. The skin is not yet broken, but the underlying tissue has been injured, and prevention measures must be intensified to stop further damage. A is wrong because stage 2 involves partial thickness skin loss with a shallow open wound or blister. The case described still has intact skin, which rules out stage 2 and points toward an earlier classification. C is wrong because stage 3 involves full thickness skin loss with subcutaneous tissue visible. The presentation does not match an open wound at all, since the skin remains intact in this case so far. D is wrong because stage 4 involves full thickness loss with exposed bone, tendon, or muscle. Nothing in the description matches that level of damage. The skin is closed and only redness is currently observed at the heel. A stage 1 pressure injury is the earliest and most reversible category. The skin remains intact, but localized non-blanchable erythema signals that underlying tissue has already been damaged by sustained pressure or shear. Pressure injuries develop when soft tissue is compressed between bone and an external surface. When pressure exceeds capillary closing pressure long enough, blood flow stops, oxygen delivery falls, and cellular damage accumulates in that zone. The highest risk sites are bony prominences, the sacrum, heels, ischial tuberosities, trochanters, and elbows, where bone presses tissue against an unforgiving surface like a mattress or chair. The defining test is the blanching response. Healthy skin blanches white under finger pressure and refills quickly when released. In stage 1, the capillary bed is already damaged or congested, so the area stays red. It cannot blanch normally. Stage 1 must not be confused with other stages. Stage 2 requires an open wound or blister. Stages 3 and 4 involve full thickness loss with visible deep structures, and deep tissue injury shows persistent purple or maroon discoloration. Stage 1 is intact skin. Catch it early and progression can often be stopped entirely. Question 42. A nurse performing a sterile procedure realizes that the sterile drape was touched by a non-sterile gloved hand during the early steps. The patient is awake. The procedure is partially set up, and the nurse must decide how to recover safely from the break-in technique. Your options are A. Continue procedure with extra disinfectant. B. Cover the contaminated area with a towel. C. Apologize to patient and skip the procedure. D. Replace contaminated items and restart setup. Take a second. Which answer would you pick? The correct answer is D. Replace contaminated items and restart setup. D is correct because replacing the contaminated drape and any affected items and restarting the sterile setup is the only safe recovery. Sterility cannot be restored at the bedside, and continuing with contaminated equipment risks infection at the procedure site. A is wrong because adding disinfectant during a sterile procedure does not restore sterility and may damage tissue. Disinfectant solutions and antiseptic preparations are not interchangeable, and the procedure cannot proceed with contaminated equipment under any circumstance. B is wrong because covering the contaminated area with a towel does not address pathogens already on the drape. The hidden contamination remains a risk, and the procedure must be restarted with new sterile materials at the bedside. C is wrong because skipping the procedure altogether is generally not necessary. The nurse can rebuild the sterile field rather than abandon care. The patient still needs the planned procedure, just with new sterile setup and equipment. When a sterile field is compromised mid-procedure, there is only one correct response: stop. Discard the contaminated items and rebuild a fresh sterile setup. Understanding why this rule is absolute requires understanding the binary nature of sterility itself. Sterility has no middle ground. The moment a non-sterile surface contacts a sterile field, microorganisms transfer onto it, and no amount of additional antiseptic, towel coverage, or careful avoidance can reliably remove them. The field is either sterile or it is not. Microorganisms introduced into a sterile site can cause surgical site infections, central line bloodstream infections, or urinary tract infections. Each event extends hospital stay, increases cost, and can be fatal in vulnerable patients. Picture a central line dressing change. A colleague's non-sterile gloved hand brushes the sterile drape. The nurse stops immediately, discards the contaminated drape and all items on it, and opens fresh sterile supplies to rebuild the field before proceeding. Two common misconceptions: adding more disinfectant or covering the contaminated area with a towel. Both leave a compromised field in place. The only safe action is to discard every contaminated item and open a completely fresh, sterile setup. Question 43. A new nurse is being observed during hand-washing technique by the infection control nurse. The new nurse uses warm running water, soap, and friction. The infection control nurse asks how long the active scrub portion should last to be considered effective hand washing for routine clinical purposes. Your options are: A. 5 seconds is enough for routine work. B. 20 seconds of vigorous friction minimum. C. 10 seconds without rinsing fully. D. 60 seconds always required, even briefly. Before I reveal it, which one do you think is right? The correct answer is B. 20 seconds of vigorous friction minimum. B is correct because at least 20 seconds of vigorous friction with soap is the standard hand washing technique. The friction loosens organic material and pathogens so they can be rinsed away effectively under running water. A is wrong because 5 seconds is far too short and does not loosen organic material or microbes from skin. Hand washing at that duration provides only token cleaning and does not meaningfully reduce pathogen burden present. C is wrong because 10 seconds is below the recommended minimum and skipping rinsing leaves loosened debris on the skin. Both elements together are unsafe. Full rinsing with adequate friction time is required for effective washing. D is wrong because 60 seconds is longer than required for routine washing and may dry the skin unnecessarily. 20 seconds is the standard for routine. Longer durations are reserved for specific surgical scrub procedures. Effective hand washing isn't just about soap and water. It's about the mechanics behind how pathogens are actually removed from the skin. Understanding why the technique works helps you remember the standard, not just memorize it. Soap molecules have a hydrophilic end that attracts water and a hydrophobic end that binds to oils and the lipid envelopes of many microbes. Friction then lifts these bound complexes off the skin so rinsing water can carry them away. Soap alone just sits on the surface without mechanically dislodging organisms. Friction alone leaves oils and microorganisms clinging to skin. Only when both are combined for at least 20 seconds does the technique become effective. The 20-second guideline, roughly 2 rounds of happy birthday, is the minimum time friction needs to loosen the bulk of the microbial load. Every surface must be covered, and rinsing with fingertips angled downward prevents recontamination of the wrist. Routine hand washing sits between a quick alcohol rub and a full surgical scrub. Alcohol-based rubs don't eliminate spores and aren't used on visibly soiled hands. Surgical scrubs require 2 to 6 minutes. 5 or 10 seconds is simply too short. 20 seconds is the floor for safe practice. Question 44. A nurse is preparing to infuse intravenous fluid using gravity tubing. The nurse considers the principle that drop factor determines the conversion between milliliters per hour and drops per minute. Different tubing sets have different drop factors that the nurse must verify before calculating the rate. Your options are: A. Drop factor varies by tubing set used. B. Drop factor is identical across all tubing. C. Drop factor depends only on patient size. D. Drop factor changes with the room temperature. What's your answer? Commit to one before I continue. The correct answer is A. Drop factor varies by tubing set used. A is correct because drop factor varies by tubing set, with macro drip sets typically 10, 15, or 20 drops per milliliter and micro drip sets at 60 drops per milliliter. The nurse confirms the factor before calculating any drip rate. B is wrong because drop factor is not identical across tubing. Manufacturers print the value on each set. Treating all tubing as the same produces incorrect drip rates and either underdoses or overdoses the patient during the infusion. C is wrong because drop factor does not depend on patient size, only on the tubing used. Patient factors influence the prescribed rate, but not the conversion between milliliters and drops, which is mechanical to the tubing. D is wrong because room temperature does not change the drop factor. The number is a fixed property of the tubing manufacturer, and environmental conditions have no role in calculating drops per minute during gravity infusion. Drop factor is a property of the IV tubing itself. A conversion ratio printed on the package that tells the nurse how many drops equal 1 milliliter. Understanding where this number comes from is essential before any gravity drip calculation. Macro drip sets come in 3 common sizes: 10, 15, or 20 drops per milliliter, and are used for standard adult infusions. Micro drip sets deliver 60 drops per milliliter, making them ideal for slow, precise infusions like pediatric fluids or sensitive medications. The mechanism is purely mechanical. Each tubing set has a precisely engineered orifice in the drip chamber. Macro drip sets have a larger orifice, producing bigger drops, while micro drip sets have a smaller orifice, producing many tiny drops. The manufacturer measures the resulting drop volume and prints the drop factor on the package. The calculation follows a straightforward formula: divide total volume in milliliters by total time in minutes, then multiply by the drop factor to get drops per minute. Always read the drop factor from the tubing package before doing any math, and verify your rate by counting drops in the chamber for 15 seconds and multiplying by 4. The most important exam takeaway is that drop factor is a fixed property of the tubing set, not the patient, not the fluid, and not the room. It never changes with patient size or temperature. It is always printed on the package and always the nurse's starting point. Question 45. A nurse working a busy day shift is caring for a patient with severe diarrhea, suspected to be from a spore-forming organism. The nurse considers the proper hand hygiene approach after patient contact. Alcohol rub is convenient but not always sufficient depending on the contaminating organism encountered today. Your options are A. Alcohol rub for 15 seconds only. B. Quick water rinse without soap. C. Soap and water for 20 seconds. D. Hand wipes followed by glove use. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is C. Soap and water for 20 seconds. C is correct because soap and water for at least 20 seconds is required when spore-forming organisms are suspected. Alcohol rub does not kill bacterial spores, so mechanical removal through scrubbing and rinsing is essential here. A is wrong because alcohol rub does not kill bacterial spores, so it leaves the nurse contaminated despite feeling clean. Spore-forming pathogens require physical removal through soap and friction, not chemical kill alone after exposure. B is wrong because A. Quick water rinse without soap removes very little bacteria and no spores. Effective hand hygiene with these organisms requires friction with soap and full lathering of hands followed by careful rinsing. D is wrong because hand wipes do not provide adequate spore removal and gloves are not a substitute for hygiene. Wearing gloves over contaminated hands recontaminates the next patient when gloves are removed without first washing. When caring for a patient with suspected or confirmed Clostridioides difficile, standard alcohol-based hand rub is not enough. The unique biology of bacterial spores demands a different approach entirely. C. Difficile produces spores with a thick protein coat that shields the dormant cell from heat, dryness, and chemicals. Alcohol simply cannot penetrate that coat, which is why hand rub leaves spores fully intact on the skin. Spore removal is mechanical, not chemical. Soap molecules surround spore-laden debris. Friction during a full 20-second wash dislodges the particles, and rinsing with running water carries them off the hands and down the drain. Alcohol rub remains the workhorse for most bacterial and viral pathogens between routine patient contacts. Surgical scrub is reserved for sterile operative cases, but for any spore-forming organism like C. difficile, soap and water for at least 20 seconds is the only safe choice. Whenever you see C. difficile, spore-forming organism or contact precautions in an exam stem, alcohol rub is the wrong answer. Soap, friction, water, and at least 20 seconds every time. Question 46. A nurse is communicating with a patient whose primary language differs from English. The patient nods politely, but the nurse is not sure understanding has occurred. The nurse considers the most appropriate action that supports communication and safety. Family translation has known limitations during clinical encounters. Your options are A. Speak louder in English to be clear. B. Skip the topic to save time. C. Ask the housekeeper to interpret quickly. D. Use a certified medical interpreter for accuracy. Which would you go with? Lock it in before the reveal. The correct answer is D. Use a certified medical interpreter for accuracy. D is correct because using a certified medical interpreter ensures accurate communication and protects confidentiality. Family interpreters may misinterpret medical content or filter sensitive information, so the nurse arranges professional interpretation for clinical conversations whenever language barriers exist. A is wrong because speaking louder in English does not improve understanding for a patient who does not speak the language. Volume is not the issue, and the practice can also feel disrespectful or intimidating to the patient. B is wrong because skipping the topic to save time leaves important information unshared. The patient deserves the same level of explanation as any other patient, and language differences cannot become a reason for unequal care here. C is wrong because asking the housekeeper to interpret breaches confidentiality and risk inaccuracy. The interpreter must be certified for medical work, and informal interpreters often miss medical detail or may not respect privacy at all. When a patient and care team don't share a language, federal law and patient safety both require a certified medical interpreter, not a workaround. Let's look at why this standard exists and what it actually means in practice. Language barriers produce documented harm. Without accurate interpretation, patients may misunderstand their diagnosis, miss critical medication instructions, sign consents they cannot comprehend, and experience measurably worse outcomes. Family members often filter sensitive information and lack medical vocabulary, creating consent and privacy problems. Untrained staff interpreters risk misrendering critical clinical content, sometimes without anyone in the room realizing it. A certified interpreter completes formal training in medical terminology and ethics. They render every word in full, adding nothing, omitting nothing, while protecting confidentiality and remaining a neutral third party between patient and team. In-person, telephone, and video remote interpretation are all federally acceptable modes. The right choice depends on availability and clinical need, but arranging one of them is a nursing responsibility, not an optional courtesy. Question 47. A nurse cares for an alert, competent adult patient who refuses a recommended medication. The nurse considers the appropriate response that respects the patient's right, while ensuring informed decision-making. Even when the team disagrees, the patient retains the right to refuse treatment within scope. Your options are: A. Force the medication into the patient. B. Respect refusal, document, notify provider. C. Threaten consequences if patient refuses. D. Hide medication in food without consent. Don't overthink it. Which one feels right? The correct answer is B. Respect refusal, document, notify provider. B is correct because respecting refusal, documenting the refusal, and notifying the provider honor patient autonomy while keeping the team informed. The nurse confirms understanding of risks and provides additional teaching if the patient is open to further discussion. A is wrong because forcing medication into a competent patient violates autonomy and constitutes battery. The action is illegal, unethical, and harmful, regardless of the nurse's belief that the medication would benefit the patient at this time. C is wrong because threatening consequences if the patient refuses is coercive and unethical. The nurse cannot use threats to override patient decisions, and the response damages trust and may violate professional standards of care every time. D is wrong because hiding medication in food without consent is a form of forced treatment and is unethical. The deception undermines trust, and the patient retains the right to refuse, which the nurse must respect even when disagreeing with the decision. When a competent adult refuses a recommended medication, the nurse's job isn't to override that choice, it's to protect it. This principle, rooted in patient autonomy, shapes every step of the refusal process. An informed refusal requires 3 things from the nurse: confirm the patient understands the recommendation, consequences, and alternatives, document the conversation and the patient's stated reason, and notify the provider so the care plan can be adjusted. Behind most refusals is a reason: side effects, cost, beliefs, or fear of too many medications. Exploring these concerns isn't persuasion. It's ensuring the refusal is truly informed and opening the door to alternatives the team can offer. The nurse confirms the patient has decision-making capacity, listens to their concerns, reviews the risks and benefits once more, then documents everything and alerts the prescriber, all without pressure or coercion. Forcing medication is battery. Hiding it in food violates informed consent. Threats are coercive and unethical. The correct response, every time, is to respect, document, notify, and continue the conversation without coercion. Question 48. A nurse is preparing to start a unit of packed red blood cells for a patient with anemia. The nurse considers the most important verification step. Transfusion reactions can be severe, and proper identification of the unit and patient is the cornerstone of safe transfusion practice in any clinical area. Your options are: A. Single nurse identifies the patient quickly. B. Skip ID checks if unit labeled. C. Match only the room number on band. D. Two nurses verify patient and blood. Got a guess? Lock it in. The correct answer is D. Two nurses verify patient and blood. D is correct because two licensed staff verify the patient identifiers, blood unit details, and order at the bedside. The double check is required because a wrong blood product event can cause fatal hemolytic transfusion reaction in the recipient. A is wrong because single nurse identification does not meet the standard for blood product administration. The risk of fatal reaction makes a two-person check mandatory, and skipping the second verification has caused many serious adverse events. B is wrong because skipping identification when the unit is labeled assumes the labeling is correct without verification. Errors in labeling and dispensing have occurred, and the nurse must verify identity at the bedside every time. C is wrong because matching only the room number is dangerous because patients change rooms or share rooms. The standard requires multiple identifiers tied to the patient, not the location, before any blood is hung at the bedside. Before any blood product reaches a patient, a strict two-person verification process must occur at the bedside. This standard exists because errors in blood administration carry an exceptionally high consequence. Even small volumes of incompatible blood can be fatal within minutes. Both nurses check the same 4 categories separately: the patient's identifiers against the wristband, the unit's identifiers against the order, the cross-match and expiration, and the physical condition of the bag. Any discrepancy stops the process until it is resolved. When ABO incompatible blood is given, the patient's antibodies immediately attack the donor red blood cells, causing intravascular hemolysis. This cascade produces fever, chills, flank pain, hypertension, and disseminated intravascular coagulation, all within minutes of starting the transfusion. Exam writers test 3 common misconceptions: relying on only one nurse, skipping checks on a pre-labeled unit, or matching only the room number on the band. Each of these shortcuts invites a fatal error. The only correct approach is 2 licensed staff verifying all identifiers together at the bedside. Blood products sit at the highest tier of verification, above even high alert medications, because a single mismatch can kill. The 2-person bedside check with full identifier matching is the primary control that prevents wrong blood events from happening. Question 49. A nurse working the evening shift on a busy medical surgical unit is reviewing universal fall precautions for every patient. The nurse picks the action that should be in place for all patients regardless of risk score, since falls remain a leading cause of preventable inpatient harm. Your options are: A. Apply soft wrist restraints at bedtime. B. Place all patients in side-lying position. C. Keep call out and items within reach. D. Order a sitter for every patient nightly. Which one is it? Pause the video if you need more time. The correct answer is C. Keep call light and items within reach. C is correct because keeping the call light and personal items within reach is part of universal fall precautions for every patient. The action prevents reaching, climbing, and unsafe transfers regardless of formal risk screen score. A is wrong because wrist restraints are not a universal fall precaution and require an order, plus failed least restrictive alternatives. Restraints can actually increase fall injury severity if a patient still attempts to move. B is wrong because sideline position is sometimes used for aspiration risk, but is not a universal fall precaution. Many patients require head of bed elevation or upright positioning, so this is not appropriate for everyone. D is wrong because continuous sitter use for every patient is impractical and not standard. Sitters are reserved for patients with documented unsafe behavior or impaired judgment, not as a universal precaution on the unit. Universal fall precautions are the baseline safety measures applied to every single patient, regardless of how their fall risk score comes out. They exist because risk scores miss patients who fall outside typical predictors, a confident older adult with new orthostasis, or anyone who unexpectedly needs the bathroom. The 5 core elements are core light within reach, bed in its lowest position, floor clear of clutter, non-slip footwear available, and the patient oriented to the room and core system. Every nurse completes this baseline at the start of each shift for every patient. The core light in reach rule targets the most common fall scenario: a patient who needs the bathroom, cannot reach assistance, and attempts to walk alone. Reaching for an out-of-reach core light is itself a leading fall mechanism, so keeping every essential item close removes the trigger entirely. Universal precautions form the floor under all other interventions. High-risk patients receive added measures, bed alarms, floor mats, and sitters, but those are layered on top. Restraints are never a universal measure. They require an order and actually increase injury risk when a patient falls. When an exam stem says every patient or regardless of risk score, the answer points to universal precautions. Keeping the core light and essential items within reach is appropriate for every patient and prevents many predictable falls before any higher tier intervention is ever needed. Question 50. A nurse caring for a post-operative patient with a Jackson-Pratt drain considers proper management of the closed suction drain. The output is small, but the bulb has not been compressed since the prior shift. The nurse selects the action that maintains suction and supports drainage during care today. Your options are: A. Empty the bulb, then compress, then close. B. Leave bulb fully expanded after emptying. C. Compress the bulb without emptying first. D. Disconnect the drain to vent the system. Take a second. Which answer would you pick? The correct answer is A. Empty the bulb, then compress, then close. A is correct because empty the bulb, compress it to remove air, then close the cap. The compressed bulb creates the gentle suction that pulls fluid from the wound, and the cycle is repeated each shift to keep drainage flowing. B is wrong because leaving the bulb fully expanded after emptying eliminates the suction. Without compression, the drain cannot pull fluid from the wound, and accumulated fluid may delay healing or contribute to infection at the site. C is wrong because compressing the bulb without emptying first does not create new suction because the bulb is already partially full. The fluid must be measured and discarded before recompression establishes the negative pressure on the system. D is wrong because disconnecting the drain to vent introduces contamination and breaks the closed system. The drain should remain a closed system to reduce infection, so disconnection is not part of routine emptying or maintenance. A Jackson-Pratt drain uses negative pressure to continuously remove fluid from a surgical wound, preventing collections that could delay healing or cause infection. Understanding how the vacuum works explains why every step in the management routine matters. The drain consists of a thin perforated tube placed inside the wound, connected by tubing to a soft compressible bulb. When the bulb is compressed and the cap is sealed, the elastic walls try to expand back to their original shape, creating a vacuum that continuously pulls fluid through the perforated tube. The correct sequence is always empty the bulb first, then compress it flat while the cap is still open, and finally close the cap to lock in the vacuum. Skipping or reversing any step destroys the negative pressure the drain depends on. Leaving the bulb expanded eliminates the vacuum. Compressing without first emptying creates no new suction because the bulb is already partly full. Disconnecting the drain breaks the closed system and introduces contamination. Skipping documentation means lost output data critical for post-operative assessment. Whenever you see a Jackson-Pratt drain question, anchor on one principle: the closed system only works when the vacuum is actively maintained. Empty first, compress the bulb flat, then seal the cap, restoring suction and keeping the surgical site dry.
You have reached the end of our study video. For the free complete exam preparation, visit our website link in the description, and you can find thousands of practice questions and comprehensive study guides on our website. Thank you for studying with us today. See you in the next video.